各位与会的贵宾，欢迎各位来到2025台湾全球健康与福祉论坛第2天的议程，台湾健保30年，共创永续未来。我们的活动再过几分钟即将正式开始，请各位就座，并且将您的行动装置调整为震动或者是静音的模式。Ladies and gentlemen, good morning. Welcome to day 2 of the 2025 Global Health and Welfare Forum in Taiwan. Taiwan National Health Insurance at 30 toward a sustainable success in the 21st century. Our program will begin very shortly. Please take your seats and switch your mobile devices to silent or vibration mode. 本次的论坛为了响应环保，现场不提供纸本的资料，请各位扫描名牌上的 QR code 下载会议手册。非常感谢您的理解还有配合。So, in support of sustainability, printed materials are not provided. Please scan the QR code on your badge to access the digital program. Thank you for your understanding and cooperation. 另外呢，需要登录公务人员学习时数的来宾，请每天在活动到场还有离场的时候，携带您的识别证到我们的报到处，扫描 QR code 来进行签到。我们今天的议程包含4个平行的场次，还有主题演讲3。So there will be 4 parallel sessions taking place today, as well as plenary 3. 那么 parallel session 2跟4会在我们本场举行。Parallel sessions 2 and 4 will take place in this room, room 201. 另外呢，Parallel Session 1 and Parallel Session 3请到1楼的 Room 101参与。Parallel Sessions 1 and 3 will take place on the first floor in Room 101. So with that, please take your seats. We will begin in a few moments. 那请各位准备入座，我们马上就要开始我们今天的分会场的场次。谢谢大家。各位与会的贵宾，各位专家先进，还有各位线上收看直播的朋友们，大家早安，大家好！非常欢迎大家来参与我们的平行场次2。这个场次的主题为 Novel Integrated Care for Whole Person Health. Ladies and gentlemen, distinguished guests, and also those of you watching the live stream online, welcome to Parallel Session 2, titled Novel Integrated Care for Whole Person Health. 我是今天的司仪 Grace 黄志杰。My name is Grace Huang, and it's a pleasure to be your MC today. 我们接下来呢，这个场次将会有2位座长。We will have 2 moderators for this session. 那接下来呢，请各位一起欢迎我们今天的第1位座长。So please join me to welcome our first moderator, Professor Cheryl Lin, Co-Director of Policy and Organizational Management Program at Duke University, United States of America. 我们首先呢，欢迎我们的座长林倩蓉老师，杜克大学政策与组织管理研究中心共同主任以及教授。我们将时间交给林老师。
Good morning. Well, distinguished guests, friends and colleagues, good morning. Thank you for joining us this morning. As the MC said, I'm Cheryl Ling. I'm a faculty member at Duke University and also serve as co-director for the Policy and Organizational Management Program. Together with my co-convener, Professor Bigwei Chu, we're honored and delighted to co-moderate this session this morning with 4 very passionate and dedicated leaders from the United States and Hualien. They will share their insights and innovative approaches about integrated models of whole person care that encompasses not just treatments or preventions, but also meaningful considerations of cost, quality, equity, and continuum of care. Our first speaker is a leader in health policy with deep experience bridging public, private, and community health sectors, Professor Chris Collard. He is president of the Milbank Memorial Fund, a 120-year-old endowed operating foundation with a mission to improve population health by connecting leaders and decision makers with sound evidence and practices in order to inform policy. Professor Collar is also the publisher of the Milbank Quarterly. Many of you probably are familiar with. It is a multidisciplinary, peer-reviewed journal, currently with an impact factor of 6.2. Before joining the fund, he served his home state of Rhode Island as the country's very first health insurance commissioner for 8 years, from 2005 to 2013. It is nationally recognized for its comprehensive commercial rate review process and the effort to use insurance regulation to promote payment reform, primary care revitalization, and delivery system transformation. Previously, Professor Collar was the CEO of Neighborhood Health Plan of Rhode Island for 9 years, and also the founding chair of the Association of Community-Affiliated Plans. Professor Collar has a bachelor's degree, summa cum laude, from Dartmouth College and a master's degree from Yale University. He is also on the faculty of Brown University School of Public Health. In recognition of his national influence, Professor Collar was elected to the National Academy of Medicine, and I quote, for influencing the alignment of private and public healthcare policy to achieve systemic progress in population health and cost effectiveness. So without further ado, please join me to welcome Professor Chris Collar.
I don't think we need this. Thank you very much, Professor Lin. Let me test this, make sure it works. Yeah. Thank you very much, Professor Lin. And on behalf of a number of folks from the United States, I want to say congratulations to Minister Xu, the Ministry of Health and Welfare, on the occasion of your 30th anniversary of national health insurance. It is truly an example for the entire world, which is why people come here to learn from you folks. So we thank you for the privilege of being able to come to the conference and speak to you. Make sure I get this. It's not going. Oh, there we go. To do this? Okay. So today I want to talk to you about just a little bit about the Milbank Memorial Fund, talk about trends in cost and quality in the United States, and then talk a little bit particularly around what states in the United States are doing to address these trends, to improve these trends, and then talk about recent federal changes. For those of you who were at the conference yesterday, the United States did not fare particularly well, and I want to talk a little bit about our performance and what we are doing to address it. So this is the Milbank Memorial Fund. Professor Lin spoke about this. As an operating foundation, we work with leaders, mostly in government, mostly in state government, to improve population health and health equity. And we do it in the 3 ways that are mentioned here. What I would say, if you want to understand the United States, most importantly, is what a big and diverse country it is. This picture is of population density in the United States. And it's important to understand when we are physically big, we have many, many people, and they are spread across the country. So the areas in white have virtually nobody living in those places, and the dark red is where the population density is. And this really, I think, helps you understand how we make policy in the United States, because it has to satisfy all these people, and it has to be a balance between a national government and state government, which, as I'll talk about, there are certain authorities that go to state government and certain to national, and that makes the responsibility of improving health, it rests in part with the national government, with the state government, with local governments, and with individuals. And so trying to coordinate among those makes it very challenging if you're trying to improve population health and health equity. The second thing to understand is how much money we spend on healthcare in the United States compared to other places. We are on the far left. This is the percentage of our economy that goes to healthcare. That means that that is money that is spent on healthcare that is not spent in other places, perhaps on things that can improve health. You heard Dr. Benjamin talk about the social determinants of health. It also means that those are jobs. Those are people who are working in healthcare who derive their income from it, and that makes change very challenging. This is an interesting slide in showing that while we are spending a lot of money on healthcare in the United States, our costs are actually rising at the same rate as other places. You heard conversations yesterday about, is it time to invest more money in healthcare? This is just comparing our healthcare costs to our rise in GDP, and it's actually fairly similar to other countries. What is much more complicated is where that money comes from. And I apologize, this is going to be a little bit, we're going to talk a little bit about this. Money, you can get your health care coverage in the United States from 3 different sources. Medicaid is for low-income people, and that is actually controlled by state government. Medicare is for elderly people, that is controlled by the federal government, but the most people get their coverage through that ESI, which is employer-sponsored health insurance. That is money that comes from employers directly to pay for health care. It is not controlled by the federal government, and coordinating those becomes very, very hard. Among other things, it means that the same provider can get paid very different rates depending on, for the same service, depending on who is paying. And so it makes coordination to improve, for payment, for delivering care very challenging because the sources of money are very different. We talked yesterday about the OOPS. What the important thing to understand here is this is a map of the OOPS in the United States. This is the portion of healthcare that is being paid for by individuals. And as healthcare costs go up, it is not the federal government or the state government that is paying more, or the employer. It is the patients who are paying more. So as healthcare costs go up, we are seeing more and more money paid by individuals, which is affecting their access to care, and it's also making people dissatisfied with the care that they are getting. The other thing is, while we are spending all this money, we are not necessarily spending it in the places that improve population health and health equity. You talked yesterday, we heard from folks in Europe about the importance of spending money on primary care. We do not do that in the United States. This is a major priority of my organization. We're going to hear from other presenters today about efforts to strengthen primary care. But primary care in the United States is undercompensated compared to other specialties, and we have fewer physicians and clinicians who are choosing to go into primary care as a result. So we are not going to address the trends that we're talking about today until we strengthen primary care. So let's talk a little bit about trends in quality, and then we're going to talk about what states are doing to respond. This is mortality rate for the United States in green compared to comparable countries. You can see that our mortality rate is declining slower. So we spend all this money, we're not getting much for it, and we did not do very well during the pandemic. You can see how we responded particularly poorly compared to Taiwan, which had a very strong and effective pandemic response. In terms of outpatient care, you talked about your 3 highs yesterday. This is how we do in terms of the people who are coming into hospitals for chronic conditions. You can see for the United States, we admit a lot more people for chronic conditions than comparable countries in Europe. We are in the green. That might be because of poor management or poor prevention. Once you get admitted into the hospital, the quality of care that's received is generally quite good. This is a broad generalization, but you can see again the United States is in the blue, the green, and other countries are in the blue. And for heart attack, stroke, and I can't read the, also stroke, different kinds of stroke. The care is relatively similar. So I want 2 points when I talk about how states are responding. First of all, this is a map of life expectancy. And so you see red is bad, blue is good. There is a 25% difference on how long you can expect to live based on where you are born in the country. So the red is particularly poor, and you can see that that's concentrated in one area. The reasons for that are actually not related to the healthcare system, but what Dr. Benjamin was talking about yesterday, what we call the social determinants of health. States are responding to this, and what I want to do is spend a little bit of time about trends in how state governments are responding to this. First things, paying attention to affordability. States are trying to coordinate between Medicaid, Medicare, and commercial insurance to really look at the overall amount of money that's being spent on healthcare. We at the Milbank Memorial Fund do that. Think about the difference in Taiwan, where you have a national payer, so you can keep track of this. And in the United States, you have to track many, many different payers to coordinate the data. This is the work that we do. We try to get people at the state level to understand the costs that Medicaid is paying, Medicare is paying, and commercial, and look at the data together, and then get them to understand what is driving costs and what can be done about it. I won't spend time on the benefits of this, except to say, in the United States, when you have so many different payers, the easiest way for make something cheaper for me is to make it more expensive for you. I want to pass my costs on to you. And what we're trying to do differently here is to actually look at the costs altogether, to take what we call a systemic approach. These are the states that are participating. We've worked with these 5 states and the Peterson Center on Healthcare to try to do this work. This is an important slide, and I want to understand. So we've been able to compile the data and bring it together. This is the average annual growth. The blue is commercial, so employer-sponsored insurance. The orange is Medicare, and the green is Medicaid. So different people responsible for paying for this. This is a very common phenomenon. Medicaid and Medicare set prices, like you do in Taiwan. In blue, it is negotiated. And so what we're finding is that the providers are negotiating higher prices from the insurers because they don't have price controls, and the employers are paying for that, and that results in the oops that we were talking about before. So this is something that economists understand, but most people do not, and so we're trying to educate people on this. The second piece is, and again, this might be easy in Taiwan, but it takes work to actually understand where the money is being spent. And so we can now say it's being spent in pharmacy and it's being spent in hospitals. And what can we do about that to try to address if you think that there's too much money that is being spent? And then the third piece of good news is states are actually responding. So we don't have to get into detail, but these are some of the policies that states are doing to say, what can we do to control prices in hospitals? What can we do to control prices in pharmacy? Because again, we have all these different payers, so we're trying to coordinate this work rather than just make someone else pay more so that I can pay less. The bad news is that we set a target for how fast we want things to grow. We want them to grow at a rate of inflation or maybe lower, and that's not happening. So part of the lesson here is that what the states are doing is good, but it's not good enough. We need more oversight if we're concerned about the price of healthcare. And now I want to talk about some things that are happening separate from costs, how states are working with this. The first is around, okay, we've seen primary care as a problem. What can we do to strengthen primary care? In Maryland, they are working very hard to coordinate the activities of Medicaid, Medicare, and commercial to pay for high-quality primary care. The good news is when you do that, you can get better quality measures and fewer people dying from COVID. So Maryland has actually shown that it is possible to do this, to strengthen primary care, and you're going to hear from presenters later this morning after me talking about how they've done this in other states. The second area, you heard Dr. Benjamin talk about addressing social determinants of health, the things that actually cause people to be sick. Remember our diagram, poor causes sick, sick causes poverty. So we are using in North Carolina Medicaid to pay for non-medical services, food, housing, transportation, and domestic violence, to treat that, to reduce the causes of poor health. They're showing results for that. However, it is hard to get this care to continue to pay for this when states have tight budgets, and that's come under pressure in North Carolina. The third example is trying to coordinate between Medicare and the federal government and the state government. So the President Biden's administration started this project called Achieving Healthcare. They called it equity. Now we have to call it efficiency through accountable design. It's continuing in the Trump administration. And this is an effort, remember we talked about how the federal government coordinates Medicare and the state government does Medicaid. This is an effort to coordinate that and also to have global budgets so that sort of like how we pay for education. We have a set budget and we understand it. This is a very big change from the normal fee-for-service business that the U.S. operates under. It is just getting started, and we'll see if states are successful in doing this work. This is the goal, that what we're trying to do here is to have a delivery system that is more focused on primary care, more focused on the social determinants. We think that to do that, you somehow have to have some sort of budget, and you have to have payment reform. So all these efforts are trying to make that more likely to happen so that we have money that can strengthen primary care. And I can't emphasize how hard it is to do in a multi-payer system. When you have Medicaid, Medicare, and commercial payers, it's much simpler, and this is why Professor Reinhardt said Taiwan set up a single-payer system. It was very wise. I wish he'd come to the United, well, he tried to do it in the United States, but was not successful. Let me make sure I get the, yes. The last thing I want to talk about in the time remaining is to talk about changes in 2025, because they have been significant with the election of President Trump and his administration. And we talked, Professor McKee talked about this yesterday. From the executive side, the administration has issued what we call executive orders. They're almost like laws that has resulted in contract terminations and agency reorganizations. There's been disruption at our public health agency and a smaller role. We depend on the national government to generate evidence for states to make policy, and there is less capacity to do that. Even more significantly, this summer, Congress passed what we call H.R. 1, a law that, when it's put into place over the next few years, will reduce the number of people in who have insurance through Medicaid by $15 million and will reduce the amount of payments going to state governments. I cannot overstate how important these changes are. We are giving more responsibilities to the states and less ability to act on the issues that we talked about here. However, this issue of what is the national responsibility and what is the state responsibility has been going on. This is a picture of the founding of our country 200 years ago. It was founded on disputes between what does the national government do and what does the state government do. We continue to live that out in terms of thinking about just when we talk about improving the public's health, how much of it is decided locally. And I'm sure that's a pressure for every country, but it's a particular challenge in the United States. It's being played out again here in 2025. So this is where I want to end with the presentation. We see that we talked about the trends that the U.S. has in healthcare, how we are spending much money. We don't always get particularly good quality for it. And the states are trying to enact policies that can help address these things. That depends on trying to get good data across all these different payers and to engage the public to help them educate them to understand what's going on. And they're responding to the importance of evidence around primary care and the social drivers of health. I want to note, actually, I have two challenges listed here. There's a third. The most important challenge is we have so many different payers. I can't say how much. The way to make it cheaper for me is to make it more expensive for you. And we're trying to get Medicaid, Medicare, and commercial to see things the same way. There's a challenge of coordinating with the federal government. And some of that is just complexity. It's made more complex this year, but when we have 50 states, the piece that I don't have in there, again, this came up yesterday, is the challenge of providers. So we set rates in the United States for Medicaid and Medicare. We don't set rates for providers. and those in commercial insurance. And those providers have become employers. So when you go to politicians and you say, look at how much money we're spending, they say, yes, but those are jobs, and I want to have people have jobs. And so there's a tension trying to maintain that. And then the third point I would say is what we closed with, is that national politics are giving more responsibility to states to address these issues and fewer resources to do it, which is why it's such a privilege and an honor for us to come to Taiwan and learn how you folks are doing it, doing this work so that we can take our lessons back with us. Thank you very much.
Okay. Thank you, Professor Collar, for that very insightful presentation, illuminating the complexity, challenges, and some of the responses across the state regarding insurance, healthcare, and costs. For our second speaker, I have the honor to introduce a visionary leader who brings a remarkable blend of rigorous cancer research, patient-centered care, and dedicated leadership in addressing cancer equity, Dr. Steve Petierno. He is Deputy Director of the Duke Cancer Institute and Charles D. Watts Distinguished Professor of Medicine at Duke University. Dr. Petierno is highly respected internationally for his profound and sustained contributions to the field. His groundbreaking translational research focuses on the genomics molecular biology of cancer disparities, molecular pharmacology, and targeted therapeutics to control prostate, breast, colon, and lung tumor aggressiveness, which includes pioneering studies on the alternative RNA splicing and ancestry associated variants. Previously, he served as Executive Director for the George Washington University Cancer Center. Since joining Duke in 2012, Dr. Petierno has helped shape the Institute into a global champion, not only for precision oncology and clinical care innovation, but also embedding equity, patient navigation, survivorship, and community outreach into the overall comprehensive care design. He was the 2019 recipient of the prestigious American Association for Cancer Research Distinguished Lectureship on the Science of Cancer Health Disparity, noting significant work with long-lasting impact on the etiology, detection, diagnosis, treatment, and prevention of cancer. He was the co-author of the Congressional Briefing on Cancer Disparity Progress Report 2022, providing specific recommendation to the U.S. Congress for achieving health equity. Dr. Petierno holds a bachelor's degree in pharmacy from the University of Connecticut, a PhD in molecular pharmacology from the University of Texas Health Science Center, MD Anderson Cancer Center, and completed a postdoc fellowship in molecular oncology at the USC Norris Comprehensive Cancer Center. He exemplified the leader who unites deep science, bold operational change, and equity-driven impact. Today, he will share with us a first-of-its-kind model led by Duke, which places primary care physicians as full partners in the cancer care team for more effective continuum of care, both medically and financially. So please welcome Dr. Steve Petierno.
This one, okay. All right. Good morning, everyone. It's great to see you. What a fantastic day yesterday. And congratulations again on the 30th anniversary of the National Insurance Program in Taiwan. Absolutely extraordinary. Thank you to Professors Tu and Lee for the invitation to speak today. And it's been my honor to host a contingent from Taiwan every year for the last 14 years at the Duke Cancer Institute. And it's been very fun to come back here these 2 days and meet people that have attended Duke and are now in very senior leadership positions in Taiwan. So that has been a very exciting part of the day today. What you heard from Professor Kohler was a sort of a bird's eye view of the United States healthcare system. I'm actually going to do a deep dive into a systems intervention to try to demonstrate to you an intervention that could lead and help support what we call and what's been called value-based medicine. So the title of my talk is Bringing Primary Care Back into the Continuum of Cancer Care. Okay, in the United States, we're usually required to show our disclosures, so those are my disclosures, and I'm going to go right past those. Okay, it's going the wrong way. All right. Whenever I speak, I like to start with the most important thing, the patient. So this is a patient that was seen at Duke. Mr. MB is a 55-year-old African-American male with COPD, wage-earning job, no health insurance, no car, seen in clinic for the underserved with an acute visit for dyspnea, had not been seen in the clinic for 16 months. After addressing the dyspnea, the provider noticed that he'd lost 25 pounds since his previous visit, asked if he had ever discussed cancer screening, either colonoscopy or PSA testing. The patient noted that no one in my family has cancer, so I don't need any of that, and I don't want to be experimented on. He declined lab work and colonoscopy, so no PSA testing was done. 3 months later, he presented in our emergency department with back pain, leg weakness, and was found to have spinal cord compression, that is PSA of 1,300, and you can see from this radiology image, he's got metastatic prostate cancer in multiple places in his body. So the question then becomes, why did Mr. MB present to us with high-grade metastatic cancer? Well, this is what the healthcare system looks like to most people, at least in the United States. You all have solved this area right here, the uninsured or underinsured, with your extraordinary policy. But the truth is, patients still experience all of these other barriers: literacy, how to handle childcare when you go to see a doctor, perceptions and beliefs, employment and lost wages, language problems, fear, transportation challenges, and comorbidities, and the others that you see there. In the United States and in other places around the world I've spoken, it remains today that transportation is the #1 barrier to quality medical care. Just transportation alone, being able to get to where you have access to the health care that you need. So for Mr. MB, these barriers played out in the real world by impacting the stage of disease at diagnosis and lack of access to primary care. So if you look all the way to your right, this is a report, a very famous report from the Institute of Medicine called From Cancer Patient to Cancer Survivor. That used to be thought of as the only black hole in cancer care. But we also know now that there are 2 other black holes in cancer care. One of them is the transition from being a non-cancer patient to a cancer patient, what we call the primary care black hole. What we know is that if a person is seeing primary care physician and they get screened for cancer and they get a positive diagnosis or a suspicious finding, they often disappear inside of a cancer center and don't reappear until 4, sometimes 5 years later after active treatment has begun. And then they might go back to their primary care doc and say, I'm back, And look at all these problems I still have and all these new problems I have because of being treated for cancer. And then there's another black hole, which is from pre-cancer patient with diabetes and high blood pressure to a cancer patient with the same. So most of you know that cancer is a disease of aging. And what that means in practice is that more than half of our patients come to us with underlying cardiovascular disease, underlying diabetes. And now we have to treat cancer in that context. And that becomes a very complex endeavor. And we're challenged inside the system with different perspectives. The oncologist perspective is, well, they want to see their healthy survivors because that helps them get up in the morning and go back to work. There's a trust bond with oncologists because there's a life-saving event that has gone on. There's difficulty finding PCPs who have the courage to treat a cancer patient or a cancer survivor. There's a lack of risk-stratified approaches. Systems are still operating in a volume-based manner, and oncologists still think that they can manage non-cancer health needs despite the complexity of modern cancer therapy. On the other hand, the PCP's perspective is there's that black hole I just described, PCPs excluded from care team after diagnosis, poor communication with the oncology team, complexity of care, systems still operating in a volume-based manner, and a lack of consistent guidelines. So at Duke, what we did is create a very unique center that's now being replicated across the nation called our Center for Oncoprimary Care. I personally recruited Dr. Kevin Effinger, a renowned family practice physician who was at Sloan Kettering, and Dr. Cheyenne Corbett, who lead this program. It includes 48 members, crosses 6 departments, 44 primary care clinics across 7 counties with 400-plus providers, and all on the same EHR. That's actually quite important, and you'll see why in just a moment. The aims of the center are to deliver evidence-based, patient-centered, personalized health care across the whole continuum, to conduct innovative research, to train and educate primary care clinicians and researchers to extend this mission, and to generate policy to lead to practice redesign. And this is sort of the cartoon that we practice by. At the top, you have cancer prevention, and our center is helping to reduce societal costs and improve outcomes through cancer prevention. And then screening, cost reduction from more appropriate focused screening strategies, cancer detection, less duplication and unnecessary testing at the time of diagnosis, improving comorbidity during cancer therapy with fewer ED visits and hospital admissions, and improving long-term outcomes, and then survivorship, that is, at the end of treatment, more efficient access to oncologists for newly diagnosed patients, that is, opening up the oncologist templates for more new patients as we're offloading survivors into oncoprimary care, and lowering out-of-pocket costs for those patients, and then when end-of-life care is appropriate, improving utilization of end-of-life care. So I'm going to give you an example. I'm going to use prostate cancer as the example today, and I'm going to touch on 3 topics: screening and early detection, management of comorbidities, and then survivorship and chronic cancer care. Well, in the United States, with a very diverse population, the incidence of prostate cancer is also very diverse. And what you see here on the left, on your left is incidence, and on the right is mortality. And you can see that there is a 1.6-fold difference in incidence rates between blacks and whites in the United States, and there is a 2.4-fold differential mortality between blacks and whites in the United States. If you compare African Americans to our Asian population, it's a 5-fold difference in mortality. Not 5%, 5-fold. So how do you address that kind of a mortality difference? Well, how about screening? Well, look how low the rates of screening for prostate cancer are in the United States right now. Why is that? In part because in 2012, the U.S. Preventative Services Task Force made a colossal mistake, and yes, I say that publicly. They looked at 2 studies and misinterpreted the data of those 2 studies in such a way that they gave prostate cancer screening a grade D. And prostate cancer screening in the United States plummeted to all-time low levels. Many of us stood before Congress and said, this is going to lead to big problems in a few years. We're going to see an increased incidence and percentage of men showing up in our clinics with advanced stage metastatic lethal prostate cancer. And unfortunately, that prediction proved to be true. So we needed to go back to effective prostate cancer screening. And this is just some data to show you that prostate cancer screening is, in fact, effective, remembering that prostate cancer has a slow lifetime in its trajectory, a slow molecular trajectory. It takes, on average, 14 to 17 years. So when you look at prostate cancer screening, you have to look at 14 years or 11 to 17 years after. And when you do, you begin to see huge differences, positive differences in survival when screening has taken place. This is the Goldberg study showing that it detected 50% increased incidence of cancer, but also reduced death from cancer by 44%. We also know from studies done at Sloan Kettering that one of the most extraordinary predictors of death to prostate cancer is an early PSA, or what we call a baseline PSA, at age 40 to 45. And if you have an elevated PSA at age 40 to 45, it's the strongest predictor that you're likely going to have lethal prostate cancer when you're in your 70s. And so we incorporate that information into our screening strategy. We know that we want to be careful. We don't want to overscreen low-risk patients and cause overtreatment, but we don't want to underscreen high-risk patients and create undertreatment. So we designed what was called, and now called, the Duke algorithm for screening. And what you can see is at the center is informed decision-making, baseline PSA, and then based on age, a screening strategy that is risk stratified. I'm not going to go into all the details of this. This is published. And then we took that and we implemented it across Duke Primary Care, 44 clinics. This was not easy because many primary care docs had bought into the U.S. Preventative Services Task Force Declaration, and we had to go show them data and convince them that this was the right thing to do. And one way that we did this was to use our EHR and put it in the maintenance box. What that means is our primary care docs had to act on it. You can't get by the screen unless you act on it. And we built into the algorithm an indicator to each primary care doc, this patient is eligible for prostate cancer screening, and they had to act on it. And by doing that, we screened 59,000 men in 18 months and produced a very significant increase in guideline concordant screening. And we did that because of risk stratification without increasing unnecessary PSAs, and you can see the numbers both pre and post implication, and without increasing unnecessary follow-up care, just by creating a risk stratified design. This was published, interestingly, in a journal that's usually supportive of the U.S. Preventative Services Task Force, but they were excited to see this data, and this data led to better screening, precision screening. We presented this to other medical centers throughout the state of North Carolina. I was invited to present it to the North Carolina State Legislature, and this screening guideline was adopted as the state policy for prostate cancer screening. It has since been adopted by 9 other states and 1 other country, which I can't name. One of the things that it did is it created a small problem. When you screen 50,000 men, you're going to find some young men with clinically significant cancer. So we did find 564 men with clinically significant cancer. 49% underwent biopsy. Of these, 20 were positive for prostate cancer. And what we did to address this was to create a virtual e-PSA screening clinic within our onco primary care and a prostate cancer screening navigation program to facilitate care of these men. So what about integrating PCPs into the continuity of care? Well, this is an embarrassing slide. This is what we call dirty laundry inside our own medical center. This is a breast cancer patient at age 42. And you can see here that this patient, after they were diagnosed with cancer, their treatment for their underlying hypertension ceased, and for 4 years, their hypertension went unmanaged while they were receiving treatment. So you can imagine, this is that person that then 5 years later goes back to their PCP and says, I'm back, and look, I still have elevated blood pressure, and oh, by the way, it hasn't been treated for 5 years. This is really inappropriate when you consider that a 10 millimeter reduction in blood pressure can save lives. And if you don't do that, you're actually increasing the mortality of that patient. And this is important because this chart shows you that the vast majority of breast cancer patients and survivors don't die from breast cancer. They die from cardiovascular disease, most of which they brought into their cancer diagnosis. It was already there, some of which we exacerbated with chest wall irradiation or chemotherapy or immunotherapy that's potentially cardiotoxic. You can see the mortality index and a 10-year follow-up study, women with breast cancer dying of cardiovascular disease more frequently, and with very significant cardiovascular risk factors. So the majority of cancer patients with underlying cardiovascular disease, the majority of breast cancer patients die from cardiovascular disease, not cancer. Who manages these comorbidities during cancer treatment? Here's a slide showing that adherence to statin therapy during a cancer diagnosis plummets and actually gets worse because nobody is managing their statin therapy. But we've published that improved adherence was associated with comorbidity management by a PCP. And we're doing this now with prostate cancer. You probably all know that anti-androgen therapies have huge cardiovascular risk factors, and we are working now to manage that with a primary care doctor named John Ragsdale, who works with our geo-oncology team to manage the non-oncologic comorbidities in men with ADT therapy. And in this slide, for those of you who are health economics, this is going to blow your mind. This is each of these in this chart, each one of these boxes is the increased cost it takes to manage cancer as a function of comorbidities. And you can see each additional comorbidity adds very significant cost to cancer care. So imagine if you can use, recalibrate your system and manage these comorbidities with your PCP, with your PCPs, rather than asking your very expensive medical oncologist or medically oncology-trained nurses to manage cardiovascular disease. So this is exceedingly important when you're talking about national health insurance. And because of time, I'm just going quickly here. What this study shows, a published study shows, is seeing a Duke PCP within 90 days of surgery was associated with a substantially lower mortality rate. So even not just medical oncology, but surgical oncology. Okay, we also know the number of cancer survivors in the United States is expected to reach 26 million in 2040. It's just shy of that right now. This is a huge number of people that we need to care for. I will tell you more dirty laundry. At Duke, when I got there 14 years ago, there were 20,000 survivors who were more than 5 to 20 years out post-diagnosis, still coming back to their medical oncologist to manage their primary care needs. Their medical oncologist had become their new hero, their new doctor, and they never went back to primary care. That's an extraordinary burden on the healthcare system, because it also clogs up the medical oncologist template to where they can't take on enough new patients because they're seeing so many follow-up patients. So, is this good medicine? Is this a good use of space, personnel, money? And is there a way to stratify by risk or not? We need to monitor for the recurrence of second cancers, surveil for second cancers. We need to do prevention, because including tobacco use, physical activity, healthy diet, counseling, and targeted education. So how do we do this? At Duke, we've created what we call shared care models, where as a function of the trajectory of a cancer patient through treatment and then in the survivorship period, that patient has been told from day one that when they transition from active care, they are going to go into an onco-primary care setting, and they're going to be making that transition. Thank you. I'm just about done. So it's a shared care model. It's risk-stratified care, and we are defining the role of the PCPs, who, by the way, don't consider survivorship a phase. They often think of the patient in the context of a life continuum in which cancer was just one of the major events in their life, not the only major event in their life. We can do this with low risk, moderate risk, and high risk models, depending on the level of acuity of that person's cancer. Obviously, if they had a stage 4 cancer and they've got serious downstream problems, they need to stay under the care of a medical oncologist. But if they had stage 1 cancer and they did well with a lumpectomy, with local radiation, hormone therapy, they don't need to be seeing a medical oncologist 5 years later or 10 years later. They just need to be having their primary care needs met. So we also use advanced care, advanced practice provider mechanism to deliver this kind of care because it is intense. And so in our system, our APPs are primary care doc extenders. They don't operate on their own. They still are under the guidance of the PCPs, but using APPs is actually the way that has allowed us to ramp this up and extend it across 44 different clinics. And then we also need to support our primary care docs, and we have a supportive care and survivorship center that provides survivorship clinical services, teen and young adult oncology programs, oncofertility, sexual health, patient navigation, psychiatry, cardio-oncology, cancer genetics, tobacco cessation, and a support program with things like art therapy and occupational therapy and things like that. And these are the support mechanisms that our primary care docs can now refer their patients to. So I will stop there. Thank you for your attention.
Well, I know you might have a lot of questions and thoughts that you want to share after our two great speakers. But hold that thought. We have two more coming that would probably add to your number of questions and comments you would like to share today. So allow me to introduce our next speaker, Dr. Tom Roth. It is my great pleasure to introduce him. He is the CEO and president of the Community Care of North Carolina, widely recognized as the nation's largest and longest running medical home system and the national model for coordinated and community-based primary care. A family physician for more than 20 years, Dr. Roth began practice in rural North Carolina with a federally qualified health center in 1998. And today, he continues to care for patients in Burlington, North Carolina, with all the other responsibilities he has. He earned his medical degree from Columbia University, completed residencies in family and preventive medicine in UNC Chapel Hill, and holds an MPH from the UNC Gillings School of Global Public Health. Before becoming CEO in 2020, Dr. Roth served as CCNC's Chief Medical Officer and Chief Operating Officer, helping build one of the country's most effective infrastructures for case management and value-based primary care. Today, CCNC supports more than 500 practices and helps provide care to nearly 1 million North Carolinians through partnerships across Medicaid, Medicare, and commercial payers. Nationally recognized for advancing primary care transformation, Dr. Roth bridges frontline clinical insight with system-level reform, aligning payers, simplifying quality measures, and championing strong, supportive family care and primary care as the foundation of a sustainable health system. Without further ado, please now join me welcoming an innovative leader, a physician, an advocate for value-based and whole person care, Dr. Tom Roth.
Thank you, Professor Tu, and distinguished guests. It is an honor to be here with you all today. Again, congratulations on the 30th anniversary of the National Health Insurance System. I must say, coming from the US, we have some health system envy that we deal with. When we come to Taiwan, it is my first time. A friend of mine, I was telling him that I was going to Taiwan this week, and he said, "Hey, can you do me a favor and just bring their health care system back with you?" So tough job. But so today, what I'd like to do is give you a vision sort of from the front line and from the field of how even small practices can become comprehensive advanced medical homes, providing them with the right supports, how they can advance health equity, and with value-based care incentives, create the incentives to not only keep them financially sustainable and viable, but also improve population health outcomes. So we'll try to show you a unique system in the US. Let's see. All right. Good, got the right direction. So a lot of comparison between the two systems, and a couple of things I want to draw your attention to. First, I want to start with the overall premise that the backbone to any high-performing healthcare system is a strong primary care system, access to comprehensive, coordinated, continuous primary care. The secret sauce here really may be the continuity, that a family physician knows you as a patient and you know them, and there's trust between the two. But to draw your attention to a few things, one is just looking at the payer mix in the United States. About 36% government programs, 54% commercial programs. In my practice, I only practice 1 day a week now, but we manage 15 different payer contracts. And unfortunately, they're all just a little bit different. Some want the quality data this way, some want the billing done that way. It creates an incredible amount of administrative burden and complexity, and that's part of what our company does, is try to defragment that system. We saw yesterday a little bit about the utilization patterns of healthcare in Taiwan versus other countries. Interestingly, in the United States, patients go to primary care about 3.2 times per year. In Taiwan, according to ChatGPT, 11 to 14 times per year. And we would tend to see 20, 25 visits per day. In Taiwan, many more. So different systems there, but we hold some of the same challenges. The increase of administrative burden and also burnout in primary care clinicians. I know in Taiwan, emergency room clinicians, it's a major issue. One of the other major differences that's so fascinating to me is the US has gone all in on value-based care. Now, your practice would not be able to survive if you weren't successful in value-based care. This makes up about 5 to 20% of our revenue, whereas in Taiwan, it looks like it's sort of 1 to 2% and advancing along the way. So very interesting difference there. So I lead CommuniCare of North Carolina. This is a not-for-profit company that really spun out of state government about 20 years ago. We have a very simple mission. We exist to ensure that every community in North Carolina has access to comprehensive primary care. And the problem we're trying to solve is that we have many small, rural, under-resourced practices that really struggle and don't have the resource to provide comprehensive primary care. So how do we do this? We, across North Carolina, we have about 1,000 sites, about 500 entities, and we try to provide the supports to make sure that each one of those practices can provide comprehensive primary care. We provide them with data and reports, very similar to what I've seen in the Taiwan system. And we also help them build a team, or we provide a team of care managers. So our view is to provide comprehensive primary care and do some of the navigation that Dr. Patierno talked about. You need a multidisciplinary team, nurses, social workers. We have a pharmacist on most of the teams, behavioral health experts. And most importantly, we have community health workers. So people that are trusted in the community and that the patients trust. So over the last couple of decades, we've developed a fairly sophisticated care management model. Each of our practices are able to deploy this model. Over on the right, we focus on the lower risk patients and provide care coordination. So this is really helping patients get their screenings done, help navigate some of the complexities in the American system. Then we move up the chain to disease management. So we identify people with the 3 highs and other chronic conditions that are in poor control, and we help those patients manage those chronic conditions, and we call them the rising risk. They're not at the highest risk now, but they're on their way. The third pillar is around transitional care management, is some of the data that Professor Collar showed around unnecessary admissions to the hospital and readmissions. Using data, we identify individuals that are going to the hospital unnecessarily, and we help them transition back to primary care, similar model to what Dr. Patierno was talking about. And then probably the most potent pillar in the care management system is around complex care management. Using data, we identify the individuals that are getting poor healthcare outcomes and overutilizing the system for a number of different reasons. They tend to have multiple chronic conditions, oftentimes a behavioral health comorbidity as well. So with those patients, we ensure they've got a comprehensive care plan, that we're setting patient-centered goals, and we're helping them move along and try to achieve their goals. Our secret sauce is really around data science, that over the last decade or so, we've developed a predictive modeling system using machine learning where we identify those patients, not necessarily that are the highest cost or going to the hospital too much, but the patients that will be sensitive to care management. Ooh, wonder how I did that. The patients that will be sensitive to care management, they'll benefit from care management. So this is the patient with diabetes that we noticed through the claims data, they haven't picked up their insulin in 3 months. When we engage them, we understand that they have problems with transportation and other barriers, as as we heard about yesterday with social determinants of health. This is the patient with a behavioral health condition that is using the ER concern that their chest pain is from a cardiac condition, but is really an anxiety attack. So shifting gears a little bit, this system has really benefited the primary care practices in terms of value-based care. In the US, one of the major policy directions to try to solve some of the problems that Professor Collar was talking about is trying to move the entire system to value-based care away from fee-for-service. And we're partway there. About 47% or so of individuals in Medicare are under advanced payment models for value-based care. But the goal is that by 2030, all Medicare patients will be in value-based care, and at least 50% of the Medicaid patients. So how do we do this for all these small practices? So the first is the use and the presentation of user-friendly data. All of these value-based care contracts have a quality of care component. I'll sort of bring one example around childhood immunizations. So this is a report for one of our practices showing what we call Combo 10, the 10 required immunizations for children under 2 years old. And this practice, you can see over the last 2 years, they've gotten over that threshold to achieve a value-based care bonus, but in this particular year, they're struggling. And as a side note, almost all of our practitioners are struggling with vaccine administration. There's a lot of vaccine hesitancy in the United States after the COVID pandemic, and this has been a major struggle. So we can identify the practices that are struggling the most and provide them with tools on how to counsel patients and how to help navigate families into getting their immunizations done. We can then look at the larger picture. So one of the major things that we've been advancing is trying to improve health equity in our provider network. So again, looking at childhood immunizations, and this is a list of a measure set of about 10 different value-based measures, that we see that Black children are immunized at 63% the rate of white children. And there's a major disparity there. And that's at the network level. We can then look at the practice level and look at a particular practice's immunization rate and then drill down on the patient characteristics. In this particular practice, they serve a large number of Native Americans, and we develop a list of those children that are not getting immunized and then use community health workers to help support those families to provide immunizations. We can then again take a step back and look at, okay, across North Carolina, regionally, where do we struggle the most? And you can see in the darker blue counties that that's where we have the greatest disparities in immunization rates. On the sort of lower side there, we've got Robeson County. The majority of that county is from the Lumbee tribe, a Native American community. And what we do in that case is we bring all those practices together that are working with this community, and we help them hire community health workers that can go into the community, usually working in faith-based organizations or with other types of community-based organizations, and help build trust between the practice and the family, and thus increasing the uptake of vaccinations. So shifting gears again, now going back to value-based care, I wanted to show you an example with real numbers of what the impact to these primary care practices are with value-based care. Remembering that a practice usually would have multiple contracts. This is one particular contract. They have 900 patients on this panel, and they've been working very hard across cancer screening, chronic condition control on blood pressure and diabetes, immunizations, and preventive care visits. With this particular payer, we get an incentive for achieving a threshold on these measures, and the more care gaps they close, the more money they make. So on average, they receive $58 for every care gap that they close, and in this particular year, received almost $19,000 from this particular payer. So again, this has really become part of the economics of how to run a primary care practice and drive these incentives. And I wanted to show you the magnitude of these incentives. So what we've been able to do is by aggregating all these small practices together and providing them the tools to work with payers and also to advance health equity, we've been very successful in helping the practices economically and also driving population health outcomes. Just as an example, I heard last week before I came to Taiwan that with one of our payers, they set a threshold for the total cost of care for a group of Medicaid individuals. And we beat that target by 1 or 2%. And it achieved a bonus of $15 million that will get spread across the network, depending on the number of patients they have in that contract. So this is critical as the costs of healthcare and maintaining a practice have increased, and as we've had workforce challenges and other issues. In the last couple of years, we've had a really strong trend of decreasing unnecessary hospital visits, decreasing by 22%, and unnecessary ER visits by about 15%. So all of this comes with a culture of collaboration. We have a tremendous amount of camaraderie between our practices, sharing insights and sharing best practices. And there is a sense of how we can take the things that are working in one part of the state and move them to other parts of the state. So we do a lot of gathering together and sharing tips and what we call pearls, and have really built a community of primary care clinicians all fighting for the same things. And our mantra is we're all in this together, and we are stronger together than we are separately. So just a couple of final thoughts. One thing is going back to the importance of, it's not just primary care, it's primary care that is coordinated and easily accessed and comprehensive. This is the backbone to both of our systems. And just to review some of our challenges, we've got this complicated array of the payer system in the United States, but there are organizations and there are methods to really help support primary care practices and help decrease the administrative burden and decrease provider burnout and increase provider well-being. And wanted to show you really the economic impact of value-based care in the States and how important this has become, and how comprehensive primary care and care management can drive health equity and improve population health outcomes. So look forward to talking to you more in the panel, and thank you again for inviting us here today.
Thank you, Dr. Roth, for such an insightful presentation. And it makes me feel proud as a North Carolinian that we have CCNC to care for our population who are in need, and so well as well. So I now have the great privilege to introduce Dr. Hui Wen-Tian. Dr. Hui Wen-Tian is a deeply compassionate physician and community leader who has dedicated her career to advancing health equity for Taiwan's indigenous populations. Dr. Tian made a bold commitment early on her path. She accepted a service contract to spend a decade in the remote mountainous township of Xiuling, Hualien, in eastern Taiwan, working with the Taroko tribe, while herself is a Bunan tribe. In a region long underserved and separated from urban centers, she brought not only medical care, but also cultural respect and enduring presence. In her practice, she addresses complex burden of diabetes, heart disease, addiction, and other chronic illness in indigenous communities. She works in a setting marked by historical marginalization, social disadvantage, and a compelling need for persistent health system innovation. What makes Dr. Tian's work especially relevant today is her fusion of frontline clinical service, community trust building, and system-level advocacy. She demonstrates how care models can be adapted for remote, culturally distinct populations, embedding health equity and community-led design for whole person care in Taiwan's health system. Without further ado, let's welcome my dear friend who I admire, a physician, guardian to indigenous communities, and visionary for culturally grounded, accountable healthcare, Dr. Hui Wen-Tian.
Malosu. Good morning, everyone. I'm Hui Wen-Tian. Okay. From the Xiuling Township Health Center in Eastern Taiwan. It's wonderful to be here, to see familiar faces, and to share how a small indigenous township built a resilient health system rooted in culture, strengthened by collaboration. In our story, culture isn't just decoration, it's our direction. And collaboration isn't just a slogan. For us, it's survival. So let's start by showing you exactly where Xiuling is and why our story have to begin there. Okay. This is Xiulin. It is the largest mountain indigenous township in Taiwan. It's home to the Turku tribe. In fact, 88% of our residents are indigenous. As you can see, the landscape is stunning, but the challenges we face are just as big. Let me show you what I mean by those challenges. Okay. We have over 16,000 people, but only one health center. There's no pharmacy, no emergency, nighttime emergency room. Isn't just a lack of care, it's a lack of access to care. Now, the visible gaps we easy to come, higher rates of tuberculosis and hypertension, diabetes. But the invisible gap, the cultural distance, is the hardest to bridge. When I first arrived over 30 years ago, an elder told me something I will never forget. He said, "Doctor, we don't feel sickness, we feel being forgotten." That sentence changed everything for me. I realized that in Xiulin, medicine alone was never enough. What people needed the most was trust. And trust only grows when culture is respected. All the listening helped us design a model that puts people and culture right at its heart. In rural indigenous areas like ours, health challenges are deeply tied to social and cultural realities. We face huge urban-rural gaps in medical resources, and it's hard to keep healthcare professionals. But just as important are the cultural differences and communication gaps that decides if care is accepted or rejected. When we learned what we as culture is not the barrier. Culture is a bridge. It's a bridge to trust, to adherence, and to hearing. And that's why cultural safety becomes the foundation for our entire journey. From the belief, we developed what we call the 5W model. It's our roadmap for culturally safe integrated care. It stands for whole person, caring for body, mind, spirit, and cultural identity. Whole household, understanding caregiving roles across all generations. Whole process, following patients all the way from screening to long-term follow-up. Whole team, collaborating with everyone, nurses, public health staff, dentists, and tribal workers. Whole risk and health, using culturally adapted tools and integrating things like oral health. This model connects medicine with daily life and family values. It's not just care for people, it's care with people. Okay, so that's the theory. Let me show you how this actually works in real life, starting with the foundation. First, we collaboration with Tzu Chi Hospital to build a family health register. This system became our basic forecast management. We focused on three simple ideas. First, empower the team. Our nurses become health coaches. Our public health workers become cultural translators. Second, engage families. We stopped just teaching and started sharing learning. We called it Sweet Families Life. Third, connected system. We made sure our local care linked smoothly with the hospitals and welfare networks. This teamwork completely transformed how we approach one of our biggest challenges, diabetes. With diabetes, our goal wasn't just to lower blood sugar. It was raise confidence. We taught family how to eat wisely, move regularly, and support one another. We created a certified care model using health coaches and community guardian angel to offer support. And the result, after the month, we saw the significant drop in fasting glucose and HbA1c. And while overall weight didn't change much, a solid 20% of participants achieved a 5% weight reduction, a key goal for prevention. But honestly, the best part was seeing families laughing together again in our clinic. We applied that same persistence to another major public health issue, tuberculosis control. In the past, Xiulin had a very high rate of tuberculosis. People were afraid of the stigma of losing their jobs, of the side effects. So we changed our strategy. We started working with tribal elders, families, and with local health gatekeepers. We listened. We accompanied them through treatment. We stopped calling it disease control and started calling it trust recovery, because we learned that no medicine works without a relationship. Let me show you the impact of that 17 years commitment. This slide said it all. 17 years ago, Xiulin had one of Taiwan's highest TB rates, over 600 cases per million people. Through 17 years collaboration with the tribal families and volunteers, we brought the number all the way down to about 100. As we build the trust, it opened the door for new kinds of innovation, even across different professionals. One of our biggest breakthrough was the medical dental integrated care program. In Dergo culture, the healthy mouth is about so much more than nutrition. It's about communication, singing, and talking and taking part in community rituals. So we combined oral care with chronic disease management. Now every diabetes patient gets a dental checkup at the same time. It's a small idea, but it brought huge change in nutrition, self-esteem, and just seeing people smile again. Next, we use technology to tackle the huge physical barriers of distance. To overcome distance, we built a digital integration system that links the Township Health Center directly with Tzu hospitals. We share records and real-time data. Even the most remote household are connected to hospital specialists. Care becomes continuous and connected. This system is the backbone for our telemedicine services. Through telemedicine, villagers can see specialists like dermatology or ENT doctors without leaving their community. This requires a whole team of doctors, nurses, and engineers working at once. Technology becomes the bridge. It doesn't replace the human touch, it amplifies it. But sometimes even technology can get through, and that when we have to create and take to the sky. During typhoon and landslide, our roads are often completely cut off. So we launched a drone medicine delivery project with engineers and local officials. Each drone carries more than just medicine. It carries a message. No one will be left behind. It's a powerful symbol of how collaboration turned innovation into compassion. So after all these efforts, what are the outcomes? Does this model actually work? Our person care model doesn't just improve health, it improves how care is delivered. Look at the cost. While the national health insurance budget grows about 5.5% per year, our care model costs grew only 1.4%. At the same time, in-town visits increase, which show us that trust and access are getting stronger. Our preventive care performance jumped from 42% to nearly 67%. And we have a 94% patient satisfaction rate. But beyond these impression numbers, let's talk about the real change, the story. So what has really changed? Trust has grown. Patients who used to avoid the health center now return. Nutrition has improved, especially after we restored oral function for our elders. I'm thinking of one senior who has stopped participating in community life. He came back simply because he could finally eat without pain. Of course, challenges remain. We are a small team with a big mission. But beyond all the data, people now tell us we feel careful, not managed. That is our real measure of success. This entire experience gives us some very important insight for the policy. This lesson from Xiulin is simple. If we want to equity, we must find trust. Cultural safety can't be a side project. It has to be a core principle of the entire system. Policy need to support prevention, family engagement, and collaboration, not just treating disease. Health equity begins when systems are designed with communities, not imposed upon them. And we believe Sholin's story offers a model for how this can work on the global scale. What we built in Sholin isn't just a local project. It's a living example of how small rural team can achieve global relevance just by blending culture with innovation. Our experience are now being sharing across Taiwan, inspiring our other indigenous and rural health systems. It proved that local wisdom really can inform national reform. And at the heart of it all, it always comes back to those two words, culture and collaboration. It is simple. Culture gives us our root. Collaboration gives us our reach. Together, they create a health system that's stronger, inclusive, and alive. When we respect culture, we restore trust. When we build collaboration, we sustain resilience. Let me close with the spirit that continues to guide us every single day in Sholin. Whole person care is only complete when it honors people's stories, their language, and their dignity. In Sholin, care, culture, community work together hand in hand and heart to heart. We've learned that even in the remote mountain, a small team can build a strong and hopeful system with compassion and collaboration. Thank you very much for your listening. One spotlight. That's terrible language, not from my Puma tribe. So I learned a lot of language from Turku. Thank you.
Thank you. Thank you, Dr. Tian, for sharing with us your experience from Sholing, Hualien County. So ladies and gentlemen, this morning we've heard 4 different talks from 4 different speakers. We started off by covering trends in healthcare costs and also quality in the U.S., performance and state activities. We heard from Professor Kohler. And then we heard from Professor Stephen Paterno on oncoprimary care, bringing primary care back into the continuum of cancer care. And then this was followed by Dr. Roth, who talked about impactability, reinventing and achieving value and health equity with coordinated team care. And we had the pleasure of hearing from Dr. Tian Hui Wen, who talked about a rooted in culture, built on cooperation, Sholing Township's journey in whole person integrated care. So with that, we will proceed with our panel discussion and interact and dialogue with the panelists to hear more of their insights and experiences, as well as to maybe take some questions from you. And with that, I'd like to invite our 2 moderators and also the speakers from this morning's session to join us on stage. So once again, please give them another round of applause. 我们再次欢迎2位主持人，还有今天上午的4位讲师一起到台上来跟各位做交流。So welcome, please have a seat. Let me now give the floor to our moderator, Professor Tu and Professor Lin.
Wow, what a powerhouse. We're in for a treat today. I know we intentionally planned the time so that we have sufficient time for interactions with our audience, whether it's here in person or through the online streaming. Will people be asking from online at all? No? Okay, maybe not. there will probably be more questions than we can handle in the crowd already. I have questions, but I'm gonna refrain from asking questions for now. Let me open up the floor and, oh, Dr. Chen. Oh, to the right, yes. Professor Chen? Oh, Professor Si and Professor Chen. Too many hands. My apologies.
I'm not sure this is on. It is on?
Yes.
Thank you so much for taking my question. First of all, I'd like to thank every speaker for the very wonderful presentations. And also, I want to pay my personal respect to Dr. For the Xiulin talk. You know, physicians like you, you are rare community. Yeah, thank you so much. And so, given that I think I should only ask one question, although I have many, I will direct my question to you. Taiwan's national health insurance has this IDS, integrated delivery system, that provides care for residents in remote mountainous areas and offshore islands, such as your community. And so the question is, how well does this IDS, integrated delivery system, meet the healthcare needs of your community? And if you could make a wish list for the government, what would be your 3 top priorities that you would ask for?
Dr. Tian? Hello?
Yeah, it's okay to answer in Chinese.
哎呦，我要怎么说呢？其实我要很感谢啦，因为我是自己人在做自己的事，所以我从来不觉得这件事情是一个政府的政策给我，而是我对自己的期许。我希望我自己的原住民的健康的需求可以被看见。那有时候这个真的是我们跟主流社会的，有时候是一些认知上面的落差。IDS 是一个非常好的一个政策，它解决了第一步，也就是把专科的诊疗真的带入了部落。那专科诊疗其实在一开始在偏乡是没有的，他们根本不知道什么叫眼科，什么科，什么都不知道。但是慢慢的，他们了解了，这些专科医师进去，但是我们还是会发现到健康还是有一些 gap 在。为什么？那就是我刚刚所提的，你进不去他们，你进不去部落里面，你只有满足到医生坐在那里，他来看你，但是你真的不懂他在说什么，他心里在想什么。那其实这个是我身为原住民，有时候我觉得是一个工作者，所以我了解医疗，我也了解我的文化，所以我可以在中间做一个很好的一个沟通。我知道要怎么样带入他们。其实最重要一点，真的就倾听他们。听他们希望他们自己的健康是什么，只有这样，你才能带领着他们走向你想要带给他们的健康。当你的手握不到他的时候，他永远就是在那里跟你说：“好，是主任，我会。”永远做不到那个健康。其实，在任何文化，在任何地区，都是我觉得都有存在着医生跟我们要服务的病患 的这个很重要的问题，就是你没办法牵着他的手跟他一起去走，因为你没有把尊重跟你会去反思你自己的给他的东西，是不是他要的？我觉得，然后我也很开心，政府现在也看到我们的成功，所以把这个全人的计划就是要到偏乡都要去做。其实，在所有偏乡，这些在台湾真的是我们的一个基础。我们真的有那个就是不管是科技的这些系统啊，或者是我们资料的建制，在台湾都是强项。所以我们很重要。我刚刚有提到的，就是我们的健康户口名簿这件事情，它是我们的一个基础。我们可以从这里进入到他们的家庭，从一个人到家庭，到整个社区。我想这是一个很好的开始。我也希望未来我们的那个原住民的健康余命可以慢慢的跟上大家的脚步。谢谢。
Yes, Professor Su.
I really enjoy your excellent presentation. The subject we have is novel integrated care for full person health. Keywords is the integrated care and full person health. But I didn't hear how consumer people themselves, what the role they play. From the perception, awareness of disease, and seek the care after that, how they play the role. That means health literacy from the people. I didn't hear any words. So how, from the integrated care and the full person health, what do you have? I would like to learn more. Thank you.
Thank you. Who would like to take the first step?
I was voted to respond. Well, I'd say it's a fundamental problem in a system like the U.S. with multiple payers and multiple programs. There's a disconnect between the care that you're receiving and the costs that occur. So one problem is that patients are not aware of, and probably a similar problem in Taiwan, not aware of that they don't need an MRI for their back pain. They don't know what the cost is. No one tells them. It's very opaque. So there is a lot of movement in trying to get patients more engaged in what the costs of care are and how the system works, and to try to educate them a little bit more. There's also, in English, one of the phrases is "no skin in the game." That patients really, there's sometimes when there's not cost sharing, that there's not engagement with the care plan and incentives for the patients to try to be healthier. So I'm stating the problems. And not sure what the solutions are in a system like ours.
I can try. One of the central tenets that the National Cancer Institute demands of the system of, in the United States, what are called National Cancer Institute designated comprehensive cancer centers, is that we all have a program for community engagement. So at the Duke Cancer Institute, I have more than 20 people under me who all they do all day long is they are out in the community within what's called our catchment area, and they are engaging with education. They're engaging to build trust. As Dr. Chen said, it's absolutely critical. It's the most underappreciated value in healthcare that most healthcare systems don't understand. You have to build trust in your community. You have to help them overcome fear and what's called medical mistrust. And then you have to be there over time. So one of the anecdotes that we talk about in cancer in the United States is we apply for a grant. We get a grant to go out in the community and do some intervention, and then the grant goes away, and then we go away. And that reinforces a cycle of mistrust. And so for example, when I moved to Duke University to help lead the Cancer Institute, I demanded resources so that our community engagement projects would be sustained and that we would try to get grants to offset the costs, but if the grant goes away, we stay in the community. And over 14 years, that has helped build trust and build education and help the community engage with us for screening, for early detection, participation in clinical trials. We have one of the highest clinical trial participation rates of any cancer center in the country simply because we are fully engaged with our community and we're building trust in the community. I couldn't say any of that in 20 minutes because the focus of my talk was on a very specific program, but we are doing all of what you said.
And I would I think in Tom's response and then Dr. Tien's, you heard two different models for engaging the patient. And we really, at least in the United States, haven't figured this out. One model is that it is a transaction, and the way to engage me is to make me pay for it. And then I have skin in the game, as Tom was saying. But the other way is to build trust. I don't necessarily trust because I paid. I trust because, as Dr. Tien said, I was listened to. And we, at least in the United States, we want both ways. We want patients to have skin in the game, to buy things. We advertise drugs on the television, if you can believe that. But when I'm very ill and I'm in Dr. Patierno's system, or when I'm feeling neglected and with Dr. Chen, I want to feel listened to. That's the different way to engage me. I have my own bias. I think I want trust. I want to be engaged. I don't trust just because I paid. But it's very hard when there's so many dollars floating around.
Thank you. Dr. Cho, please. You get all the heavyweight asking questions.
Thank you. Yeah, again, great thanks to this wonderful session with wonderful presentations. I'm Professor Shuti Cho, the former Director General of Taiwan's Health Promotion Administration. Actually, the IDS system, at the beginning, we have those previous leaders here. It addressed not only integrated care or services, but also they would like to include healthy community development in remote communities. That's one thing I would like to say. But here I have the two questions, one for Tom and the other for Tien. For Tom, speaking of disease management or shared care or collaborative care, previously we categorized our patients into different level of performance or management. But nowadays, we also know that social determinants of health influenced their patient engagement and the success of care. So I would like to know, how do you integrate, how do you address social determinants of health into your delivery of care so that we really achieve equality in healthcare performance between people with different social backgrounds. That's one question. The other for Dr. Tian, actually likewise. We know that culture is not individual thing. And in Aboriginal communities, it's not only culture. There are so many social deprivation which prevented them from collaborating with you on your care plan. So how do you address that root causes in the communities from upstream? So it's not by individual services or individual communication. We need to tackle those determinants either within a community or actually from above. So I really would like to know that. And actually, then it will not be only for diabetes or for that, the obesity issue, the gouty arthritis, but all these are associated with, for example, loss of job, alcoholism, and many other things. Yeah.
Thank you so much for that question. And I think, as you said, we sometimes put patients into categories, and we have sophisticated data models to predict what they'll do. But really, the care of the patient starts with an interaction with a care manager, a nurse, or other person on the team. And the first thing they do is connect with them and try to understand their barriers to care, including social determinants. So social determinants screening and intervention is across that entire model. One of the things that Professor Kohler mentioned is we had a unique pilot in North Carolina. For the first time, the government was paying for a social determinants intervention across 4 categories: housing, food insecurity, transportation, interpersonal violence. And so the health insurance company was paying for food boxes, was paying for transitional housing and other things. And this was a very strong intervention with saved $85 per member per year. So good cost results. So agree with you. That's the heart of the matter usually, and really the first step on a care management model for us. So thank you.
Okay. 对于那个有关不只是文化，尤其是 social determinant 这些问题，其实尤其是像我们这样是最基层、台湾最小的卫生所，我们能够做的，真的有关经济的部分啊，要改善他们的一些习惯啊，什么，其实有很大的困难。但是呢，我从来做的一件事情就是做不放弃。那我刚刚的 presentation 里面有提到，好几次都提到它很重要的一个词，哈，不管是我的health gatekeeper 或者是 guardian angel 在我们的社区，这个是很重要的我们的一个在跟这个 social determinant 在一起的一个很重要的种子。我觉得他们不管他们在什么样的经济的状态，或者是他们面临什么样的生活的不一样啊，哈，这个 guardian angel 跟我们的这个 health gatekeeper 真的是我们的一个在社区里面的，尤其是偏乡的一个小种子。他们没有受过任何的正当的这个医疗的训练，但是因为透过我们的教育，透过我们给他们的指导，让他们知道他们能够在社区里面怎么样跟他们的人说话，跟他们的人能够在一起，让他们了解没有人会放弃他们。也许有人会放弃他们，他们老板可能不要他们，但是不管怎么样，卫生所在，这些 guardian angel 在， 不管他们任何什么问题，我们都可以陪伴他们。也许都没有办法一时解决他们，但是我觉得满足他们的一种安全感，对我来说，就是卫生所可以给他们很大的一个保障。我们卫生所正式的员工只有20个，但是我 total 加起来 routine 在卫生所做这些事情的人，现在有50个。以我卫生所20个人的能力，我接了很多很多计划，然后我就养了这些 Guardian Angel。剩下来30个都是我又靠计划去培养我们在地的人。那我希望这样子的事情，最重要的一件事情就是透过这样文化安全的这样子的服务，有一点很重要，就是他们要认知他们自我照护的能力。唯有社区发展出自己自我照护的能力，他才能有韧性，才能永远永续。这是我自己的感觉了，谢谢。
I know there are still quite a number of questions out there, but unfortunately we're running out of time. So I would like to say the insights and models that our outstanding presenters share with us today are very relevant, important, and even necessary for Taiwan today, especially at the junction where the country and the health system are contemplating about restructuring the infrastructure, the payment system, the incentives for both the providers and receivers, the patients, the public, and perhaps even trying to shift some of their care-seeking behaviors while still maintaining the quality and control the rising costs. So thank you again very much for sharing your experiences, your insights, your intelligence, and especially your hearts and passion to inspire all of us. And thank you for everyone for your attention and participation as well. And I would like to conclude the session. Thank you again.
Thank you. Before we break for lunch, I would like to invite the 2 moderators and the 4 panelists to come to the center stage. We'd like to ask our moderators to present certificates of appreciation to our speakers. 我们在午餐之前呢，邀请2位座长来为我们颁发感谢状给我们的主讲人。So please come forward. I'd like to first invite Professor Cheryl Lin to present a certificate of appreciation to Professor Kohler. Thank you so much for joining us, for traveling afar, and also for sharing with us your insight. 好，请看一下我们前方的摄影镜头。Thank you very much. So Professor Kohler will be taking another photograph after everybody gets their certificate. 接下来我们邀请 Professor Stephen Paterno. 同样的也是请林教授来为我们颁发感谢状。Thank you. And now I'd like to invite Dr. Roth. 接下来我们请涂碧桂教授来替我们颁发感谢状。So this is actually Dr. Roth's first visit to Taiwan. Thank you, beautiful. Last but not least, 最后呢，我们邀请田慧文医师，非常谢谢田医师带来花莲的经验。好，最后呢，我们邀请4位讲师还有2位座长，我们再一次合影留念。So last but not least, a group photo with our entire panel and also Professor Tu and Professor Lin. 请各位看向前方的摄影镜头。So please a little bit to your left or your right. All right, give us your smiles. Thank you. 我们再次谢谢我们的主讲人，还有2位座长。Thank you very much. 也非常感谢各位贵宾参加我们今天上午的论坛。我们接下来要进行的是午餐休息的时间，请各位携带您的识别证， 依工作人员的指引前往3楼的用餐区来用餐。我们下午1点钟将会举行2场平行会议。Parallel Session 4就在我们的原场地201室。参加 Parallel Session 3的来宾，请前往1楼的101会议室。So, ladies and gentlemen, thank you for joining us this morning. We will now break for lunch. Please bring your badge and follow our staff's instructions to the dining area on the 3rd floor. The afternoon sessions will begin at 1 o'clock with 2 parallel sessions. Parallel Session 4 will take place in this room, room 201. And if you're attending Parallel Session 3, please proceed to room 101 on the 1st floor. Thank you very much, and we will see you at 1 o'clock. 谢谢大家，我们1点钟再见。 各位现场的与会贵宾，我们接下来的场次即将再过5分钟之后准时开始，请各位入座，并且将您的行动装置转为震动或者是静音的模式。我们再过5分钟即将开始我们今天下午场的议程。Ladies and gentlemen, the parallel session 4 will begin in just 5 minutes. We would like to ask you to take your seats and please switch your mobile devices to silent or vibration mode. We will begin the program momentarily. Thank you.各位与会的来宾，大家午安。我们再过2分钟即将开始我们今天下午的场次，请大家就座，也请各位将您的行动装置转为震动或者是静音的模式。非常感谢各位的配合。Ladies and gentlemen, we will begin the next session very shortly. Please take your seats and please be sure to switch your mobile devices to silent or vibration mode. Thank you for your cooperation. 各位与会的来宾，各位贵宾，欢迎大家参加 Parallel Session 4。这个场次的主题为 Global Trends Toward Better Health and Well-being. Ladies and gentlemen, welcome to Parallel Session 4 on Global Trends Towards Better Health and Well-being. 请跟我一起来欢迎本场次的座长、主持人 Professor 志宏 Jason Wang. Please join me to welcome the moderator of the session, Professor Jason Wang from LCI Tan Lan Lee, Professor and Director, Center for Policy Outcomes and Prevention, Stanford University School of Medicine, United States of America. 我们掌声欢迎王教授。
Good afternoon. Well, thank you for coming to this session. Have you all had lunch? Yeah? Feel a little sleepy? No? Don't be, because we got a very exciting program for you today. My name is Jason Wang. I'm a professor of pediatrics and health policy at Stanford. I also direct the Center for Policy Outcomes and Prevention in the School of Medicine. My own work is in the intersection of digital health, child health, and international health. So I'm particularly excited to hear from our speakers today. Our first speaker is Dr. Corina Collignon. Dr. Collignon is the head of the Digital Health Department in the French National Authority for Health, HAS. So the Digital Health Department is part of the Improvement in Quality Care and Safety Directorate, the Assessment and Access to Innovation Directorate, and the Social and Medical Social Support Quality Directorate. The Digital Health Department is also cross-functional and works on digital aspects involving in these three HAS directories activities. Dr. Collignon is a doctor of pharmacy. After specializing in hospital pharmacy, she started her career at the French Agency for Safety of Health Products before joining the French National Authority for Health. With over 15 years of experience in medical device assessment, she is a leader in adapting methods to assess digital medical devices. Currently, she has the HAS team focused on assessing digital medical technologies, including connected devices, AI-powered software, and generative AI in healthcare. Her team also develops the frameworks and guidelines to support the selection and use of relevant AI technologies in the French market. And since the HHS evaluation of health technologies aims to support reimbursement decisions in France, but does not necessarily cover all AI technologies that enter the French market, Corina's team are developing new frameworks to elaborate on the guidelines and to help users choose the relevant AI technologies. Please give a warm welcome to Corina.
Good afternoon, everyone. I'm really pleased to talk with you on AI benefits and risk, and also to present how we deal with that topic in France and what is our strategy. Just some few words to put our work into the context of the French National Authority for Health agency. Its acronym is HAS. We have at HAS 3 core missions, and we are first a health technology assessment body. That means that we evaluate health products, whatever they are, so medicinal products, procedures, also medical devices, and of course, digital medical ones. The objective of our assessment is to inform the reimbursement and pricing decision that is on the hand of the ministry. So we do not decide, we are a scientific agency. to guide the decisions. We also produce, that is our second part of activity, we also produce best practices recommendations, and we produce health guidelines also. And the third part of our missions is to measure and to improve quality of care and patient safety in healthcare, not only in healthcare, but also in social and medico-social field. We have a specific European context, and we work in a European context, and in the European Committee adopted a new law specific to AI. So it came into force in 2024 with requirements not only for providers, but also for deployers. And deployers means in the language of the European Committee, institutions like hospitals and healthcare practitioners. That means that they will have and they have some obligations that come into effect progressively between today until now and between now and 2027. Sorry. We are witnessing growing development of AI in healthcare, specifically for professional use, and most of them are digital medical devices. And there is a clear signals in favor of an increased development of AI around the world regarding the number of publications and reports, and also the investments. Actually, in France, we do not have data to precisely quantify the current use of AI in clinical practices. Only a recent study published last summer by the Union of Public Hospitals highlighted that already 65% of public hospitals has already deployed an AI system, and the report estimate that by 1 or 3 years they will be 80%. So that's a reality. New care organizations with AI system are being established. However, their usage is not always controlled by institutions. There is a lot of shadow IT, and you can put your hand on if you haven't heard about any experience of physicians or students or patients that have already used its smartphone with ChatGPT to set a diagnosis. I can see no hands. You haven't heard about that? You've never heard about that? So that's a reality. And also the difficulty for hospital governance is the multi-entry points, and they do not succeed in knowing what is really used in hospitals. So digital medical devices for professional use, of course, raise specific issues like robustness and validation in the local context. They can be really performant, but they can sometimes have to be adapted to the entry source of an hospital, for example. And professional and hospitals can fully choose, actually, to buy and use such AI system, because they do not fall in France in our assessment perimeter, and that's linked to the that's due to the fact that they are not eligible for reimbursement, for a specific reimbursement. That means that the professional can use and can choose any software that could help them with a constant tarification. And that means also that they can integrate AI system into medical procedures without being fully informed about their performance or limitations. And that's the reason why building trust and supporting informed choices is became for us really crucial for several months. I can't do that presentation without underlying the huge potential of AI in healthcare. It is clearly a lever of transforming practices and organization in all fields, actually. and its potential is major for to develop prevention strategy, also to personalize healthcare, and it's also a good way to stimulate the dissemination of information and to fight misinformation too, I would say. But there are conditions. They could be, they are a lever for transforming healthcare, provided that they serve humans, both patients and professionals. They meet real needs. They take into account issues of ergonomics and interoperability and security that are major issues, and they are used as a lever for improving quality of care and access to care. To address those challenges, we at HS, we launched a dedicated program in 2022. In order to build a new framework for digital medical devices used by professionals and AI in care, with a dual challenge to promote the diffusion of suitable digital innovation, but without adding constraints on manufacturers. We do not want to over-regulate. In Europe, we have a lot of regulations, and we do not want to put in place in France specific regulations. We work on three objectives. The first is to assist professionals in hospital in their selection of relevant digital medical devices by highlighting their decision, their choices. Is it the right device for my need? To guide them doing financial analysis, because the question is very often, can I afford it? To draw guidance also dedicated to the proper use of AI in care, and also to develop a new framework of assessment. In a few minutes, I can just give you some example of what we do to build this three-axis framework of trust, to guide the selection of relevant digital technologies. For example, in 2023, we published a guide that target the good question, the major question to ask before choosing a software, so dedicated to professionals and hospitals. We are currently working on a financial analysis guide. We want to produce a ready-to-use tool dedicated to hospitals to make them, to facilitate their financial analysis, because only large hospitals have a possibility to do such analysis, and we want to equip and to make feasible this kind of analysis for smallest hospitals. So we also support the good use of AI system in a care context. And 2 weeks ago, we published guidelines that are specific to generative AI. I would describe those guidelines as short educational guidelines dedicated to professionals in their first approach of AI use. We are now working on an equivalent of guide dedicated to patients, because we have been asked that it would be very useful to build a parallel guide to guide users, patients and citizens, because they used also their smartphone and their general app that is not scheduled to a medical use. Sorry. We also add 2 new criteria dedicated to AI in the French accreditations of hospitals. One is dedicated for digital medical devices embedded AI, and the other one is for AI system that do not have any medical purpose. The objective by doing that is to prepare hospitals to the requirements of the European AI regulation, and to also fulfill the requirements of the global regulatory context, even taken into account the existing law regarding data protection. There is a lot of things to think once adopting AI, and our objective is to guide hospitals. So we want, by adding these criteria, put them encourage them to set a framework to guide the selection in hospitals and the deployment in hospitals. By adding these criteria, we know that we can't let them halfway, and we then have to set guidelines to explain or to guide them to know how to do. So for doing that, we have first prepare a clarification of a legal and regulatory framework, and then we are producing graduating guidelines and also example of practices to avoid, and we expect to put that in place next year. At the beginning of we are finishing the guidelines, and we want to publish them, a first set of guidelines, at the beginning of the year. We also build new evaluation approaches because we are asked to enlarge our scope of assessment, but how to do with so many technologies and the grading, we have to find a new approach, probably embedding third-party evaluation, and works are on the table, and we are working on that, and also we are working on a way to develop as fast as possible the evidence that are needed to assess those technologies, because it is useless to develop a new framework without having the data to highlight the evaluation. So huge challenge for trust framework. There are also some challenges, of course, and it was already underlined by several speakers before, on data reuse. Data reuse to improve quality of care, also for research, and to get pertinent digital tools for healthcare. We have, to do that, some major issues. Data protection, interoperability are crucials. Generative AI introduce new questions in health use because they are really easy to use, thanks to their platform that allow interaction in natural languages. That's the reason why it targets new issues. And we also work on how AI can be a lever to transform our own working methods. And it's important, and we are exploring that by beginning with literature review. To finish, I will just highlight a take-home message on the three principal questions that we have to ask before introducing an AI system in healthcare. The first one is, what is the need? And of course, the need is not the same everywhere, like this glass of water in a desert and in a tropical context. There is also a major issue regarding the good use and the use in the intended use of a device. Using a screening technology is not the same as a software to help to set a diagnosis. And the most important message is linked to the organization, because I will conclude by saying that the machine without human is nothing. So we have, the first thing to do is to set the good organization around the AI system that is used. Thank you for your attention.
Our next speaker is Professor Stephen Weber. Dr. Weber is the co-founder of the Center for Digital Transformation and a professor of medicine in the section of infectious disease and global health at the University of Chicago. Until 2025, he also served as Executive Vice President and Chief Medical Officer of the University of Chicago Medicine Health System. In that role, he oversaw physician quality and practice, population health, care coordination, informatics, simulation, and innovation. And he provided co-executive leadership for the health system's digital health programming. A practicing infectious disease specialist, Dr. Weber continues to care for patients in both inpatient and ambulatory settings. Dr. Weber earned his MD from the New York University School of Medicine and completed his internal medicine residency at the University of Chicago, where he also served as chief medical resident. He pursues subspecialty training in infectious disease at the Beth Israel Deaconess Medical Center in Boston and received master's degree in epidemiology from the Harvard T.H. Chan School of Public Health. And he's board certified in infectious disease and practiced since 2022. Please give a warm welcome to Professor Weber.
Thank you very much. Thank you for that warm introduction, Jason. I want to thank Minister Xi and all the organizers, and then all of you for spending some time and wisdom with us here today. My presentation, the perspective will be a little bit different than some of the others that I think we're hearing today, although I was just saying to Corinne, there are some real similarities. I, as the introduction said, I work from the standpoint of health system leadership in the U.S. We have not benefited from particularly strong guidance or clarity around expectations around artificial intelligence from either our federal government or our local government. And so there is a lot of pressure that's placed on the leaders of health systems to make the right decisions about how we're integrating these tools. And yet at the same time, I'd submit to you that the approach that I'll talk about today, I think has parallels and can be applied at provincial levels, national levels, and certainly beyond. So to that end, I hope that what we're able to go over here is going to be relevant for everyone. The challenge we face in running health systems now is overwhelming. It's overwhelming both in terms of the opportunity that we see in terms of these new tools, in terms of these new platforms, but also for the concern that we might face with them. And we talk among my colleagues of saying that leaders in health systems, and I think at higher levels, are balancing, we'd say in English, between fear and fear of missing out, or FOMO. The concern being that if we do this well, it can be transformative. And we'll see perhaps miraculous things happening for our patients and the communities we serve. But at the same time, the errors that we might make, the pitfalls that we might fall into can have serious consequences. And as a health system leader in the U.S., the consequences can be everything from the difference between being profitable and having revenue or being unprofitable and facing closure. But more importantly, and certainly it's not just true for physician leaders like myself and many of you, but the risk that we pose to our patients and our community in our attempt to do well. And so we're trying to sort this all out. And while I'm encouraged, Mark McKee yesterday talked about demystifying AI, the fact is, even with those tools that they might be generating, the truth is that things are moving so quickly right now that it's impossible to create just a single roadmap that we can all follow. So we find ourselves relying instead on looking at the principles that we might follow. How do we go about this in the absence, for us in the U.S., of specific guidelines? How can it inform national or provincial policy around it? And when we do that, we take a very practical stance. We look to the idea of how do we go about making these decisions? And it really comes down to just a handful of steps. We talk about how do we set priorities in artificial intelligence and digital health? How do we think about ingesting that innovation? How do we go about implementing this well? And then, of course, how are we thinking about safety and security as we do all of this? So let's walk through each of those. And first we come to setting priorities. And some of this will be basic, but stay with me because I think we'll have some observations about what we're seeing, or at least I know what I'm seeing in practice. Because there's three questions we have to ask as we're setting our priorities and building out our plans around artificial intelligence and digital health. The first is, what's the problem that we're trying to solve? And I think I can upset some people back in Chicago in the US when I say, well, we don't have goals for our digital health program. And they look very confused. And I say, no, we have goals for our clinical programs. I think yesterday what Minister Shi said in talking about the goals for the programs here in Taiwan, it was not digital health goals. It was goals around longevity, goals around cancer outcomes, goals around the 3 highs, not around digital. It was the idea that the digital and the AI work is going to serve those goals. And we can't lose track of that. We have to understand that our first commitment has to be to our patients and our community that we're addressing. Having identified those problems, what are the capabilities that we need to solve them? And we know how to do this. We know it from experts in public health. We know it from experts in government and health system leadership and clinicians on the front lines to look at the challenges that we face and to say, how do we deconstruct these, take them apart, and think about the solutions that we need to address them, the capabilities to build this out? The attraction of going about it in this way is we don't find ourselves just chasing after digital and AI tools. It's a reminder that we already have capabilities. We have skills. Sometimes we're using them to our fullest. Too often we're not. And so the idea of really facing that and saying, what are the capabilities to make a change is really critical. It's only at that point that you step back and say, what are the solutions that we're going to follow? What are the solutions we'll take on? For us, we're making those decisions at an organizational or a hospital level. Again, maybe that's happening through national programs or provincial programs, but that's the beginning of the first time that we're going to think about these solutions that are coming in. And the ability to look at that next step, to say what's the solution that's going to be ideal to fulfill a capability to solve the problem, becomes an essential and very disciplined skill. And so it really comes down to how we ingest that innovation. We know there's all these pieces of digital solutions and AI solutions that are out there, but how are we going to bring them together, create that beautiful picture that's going to most benefit our patients and most benefit our systems? I know we're inundated with opportunities to adopt all kinds of new technical solutions. When I was in my senior executive role, and to this day, I'd received on any given day 10 or 15 messages coming from both established companies, investigators, startups, and others with the next solution. All of them sounded wonderful. But the fact is, to understand the capabilities of those become absolutely incredibly important. And again, the watchword that I come back to again and again is discipline. To understand that we're not starting from a solution. We're not saying, how will this solution help our patients? We started with the question, what do we need to do to help our patients? And with that coming through, we have to be able to ingest the solutions. What does that look like? Our historical approach, at least for a health system like mine, has been insufficient. The idea of managing a portfolio of IT tools looks very different when we're talking about AI and digital. First of all, the breadth of the work is far broader than what we think about in traditional IT, but also the potential benefits and risks are much greater. So I bet if you look at the teams who are making these decisions in a lot of health systems and hospitals, they're probably too narrowly minded. Certainly it'll involve a clinician, we hope, if it's a patient-facing tool. Certainly it'll involve people from IT security, cybersecurity, and safety. But we need to step back and look at the greater harm and good that can be done. And so I'd submit that we need to revisit how we look at ingesting this kind of innovation. Now, when you start talking about that to people on the front line, clinicians and others who are trying to make big change and do better for patients, they hear that we're going to add another layer of bureaucracy. There'll be a new committee, a new delay in bringing technology to the front line. There's a different mindset that can and needs to be adapted as we go about this. And there's models for this already. We look at accelerators and programs in the entrepreneurial space or in the startup space where the idea is we want to approach a problem rigorously, but we're going to accelerate. We're going to look at this not as a filter to keep technology out, but how do we safely bring it in? And that is going to require changes in how we do things historically. And so again, the idea of ingesting innovation needs to be that of adding speed, but maintaining that discipline and that rigor. So we decide on a solution. We've identified that problem, the capabilities. We decide on a solution. We implement that solution, and the value doesn't produce. Perhaps it's not the economic benefit that the company predicted. Perhaps it's not the clinical opportunity that we thought would come from it. Perhaps the outcomes aren't what we thought. When we start to look, we say, well, maybe this technology wasn't right. Or maybe our adoption was not right as we actually installed this new technology. I think increasingly, as we're going forward in this space, we need to take a closer look at our own work in implementing change. And the graph that you have up here is just something we think about a lot. We think of it as an implementation paradox. The idea, and I think this applies, again, both at an organizational level and at a higher level, is that the attention we give to new tools and opportunities peaks when we first think about it. And we say, we're going to bring in new technology, and we're excited. We're going to bring in the budget that we need to. We're going to do the investigation to ingest that new technology. We're going to spend a lot of time and money to deploy that new technology, and then we're going to bring it live. It's surprising to learn how many health systems the support that comes from information technology stops at the time of go live. We treat go live of a new technology as if it's a finish line when it's in fact the starting line to the success that comes with that technology. And so we hope that the computer-based training we might do for physicians, the tip sheets we might give to people, the online resources will be enough, whether it's a surgeon in the operating room or somebody working in finance or somebody working in social services, that they're going to figure it out. And then we wonder why we don't get the results that we expected. Of course, more often than that, we won't even know because we don't even keep measuring the impact of it. And I was glad to see some of those pieces in what Corinne was talking about. So we underinvest in sustainment and assessment, and then we wonder why we haven't gotten the benefit from a new electronic, digital, or AI tool. And so implementation is key, and there are tools to do it. There's a whole science of implementation that's called in English implementation science that looks not just at the interface between the technology and the users, but understands the user's practices before, what it can look like after. It digs in deeply to think about cognitive burden and how people will interact with that technology, sure, but how will it change the rest of their work? And it thinks about the dynamics of teams and how they come together. These are essential investments that, when they can be made, need to be made to bring the real value from the technology. You can go further with this too, and we see more and more. We have collaborations around human-centered design to, again, dig in and understand that we're not just relying on the package that came from a vendor or from an innovator, and instead saying, how can we really make sure that this has the impact we expect for our patients? Of course, we cannot talk about this without talking about security and safety. And so let me say something a little provocative here, and I'll restrict myself, just for the sake of this, to the US healthcare system. Medicine and clinical care are already unsafe. I appreciate everyone who's concerned about the safety problems that will come with AI and digital, but make no mistake, what we do right now is already unsafe. Hallucinations and bias are common today without AI tools. Dr. Benjamin talked yesterday about bias in medicine, and I don't think any of that was dependent on technology. That's what we bring as humans too often to the care of patients and think about issues of equity and equality. One doesn't need an AI model to face those challenges already, and done well, there's a potential for some of that to address and adjust, or at least shine a light on those challenges right now. And we don't call the hallucinations that exist in medicine today hallucinations. We call them things like medical error and misdiagnosis. You know, in the US, this is a paper from just not long ago from Hopkins talking about in the US, nearly 800,000 people die or are seriously harmed by misdiagnosis. That's nothing to be proud of, but it's certainly something that puts into the context what can come with AI, what can come with digital. It's not that these are miracles that are going to change everything, but to be able to address and understand that our present state is not always so good for our patients is an important acknowledgement that we need to make as we go forward. So we combat that with some of the things we talked about in implementation. We need to continuously monitor. We agree that one of the best things about some of these models is they'll change and evolve over time. Well, they need to be keep tracking. A model that started at the beginning that was very good in predicting sepsis or creating interventions may change over time, or as it goes forward, it may be less good for certain segments of the population and community that we serve. Absolutely essential. So you can look and think about safety and security and say, all right, well, this is all very concerning, and maybe we ought not to go forward. I actually remain very, very optimistic about this. And I remain optimistic, not because everything is good. In some ways, one cause for optimism here is the metamorphosis that we have the chance to do. And this is, I believe it's the broad-tailed swallowtail butterfly here in Taiwan, who itself undergoes a metamorphosis. And our metamorphosis comes about because of the struggles that we have right now, the hazards that we face in delivering care today, the difficulties that we face right now with patients being at times unsatisfied with our care, the ongoing quality and safety, clinicians who are frustrated, and an environment, though, right now that's ready for change, that's going to be more receptive to what we do. Professor Shio said something about this yesterday, too, about we're poised at a moment to make a change, and the technology can enable that, it can stimulate it. I'm reminded that 30 years ago, there was a substantial change that happened here around the delivery of care. That was a metamorphosis. I learned a lot yesterday. We have the opportunity for an even more substantial change because it's global, but it's going to depend on folks like us as leaders and the folks who take care of patients and communities to understand that we need discipline, we need a framework to think about this, and we need to remain both curious and cautious as we go forward. But again, I think the future looks very, very promising. So thank you very much for having me. I look forward to the rest of the speaks.
Our next speaker is Professor Po-Shi Chen. Professor Chen is Professor of Psychiatry, Behavioral Medicine, Public Health, and Psychology at the National Cheng Kung University in Taiwan, and currently serves as the Director General of the Department of Mental Health, Ministry of Health and Welfare for Taiwan. Dr. Chen received his medical degree from Kaohsiung Medical University. Oh, that's my hometown, Kaohsiung, yeah. And completed residency at National Cheng Kung University in Tainan. That's my mother's hometown. Yeah. Followed by advanced research training at Duke University Medical Center and the Neuropharmacology Laboratory at the NIH. A distinguished clinician scientist, Dr. Chen specializes in biological psychiatry, neuropsychopharmacology, neuropsychoimmunology, and neuroimaging, with a strong record of translational research connecting clinical practice and social neuroscience. Welcome.
Thank you, Chair, for your kind introduction. And our distinguished colleagues and ladies and gentlemen, today I will going to talk about the global perspective on the evolution and the modernization of mental health care in Taiwan. The title is a little bit different from what we have heard before, but I will talk about AI use in mental health care. And I'm Po-Shi Chen, and now serve as the Director General of the Department of Mental Health in, okay. Okay. So over the next 15 minutes, I will walk you through three main themes. The first is how Taiwan's mental health system evolved from the institutional care to a community-based and a right-based care. It's about some history in Taiwan and what we have modernized in the past 3 decades. And where we are going in the next chapter from 2025 to 2030. And how this connects to global learning and the cooperation. Okay, so first part is about history. So our story begins in the early 20th century. So when Taiwan was still under Japanese colonial rule. So in 1934, Taiwan's first public psychiatric specialty hospital, the Taiwan Government General Psychiatric Hospital, was completed in Wufenpu in Songshan in Taipei. So it later became the Provisional Taipei Psychiatric Center, and was subsequently relocated and transformed into today's Taoyuan Psychiatry Center. And shortly after that, the Department of Psychiatry was established within the School of Medicine at Taihoku Imperial University, that is Taipei 帝国大学. It's currently the National Taiwan University. So in 1939, the university opened an inpatient psychiatric ward, so which quickly became a central hub for psychiatric medicine and training in Taiwan. And this development led to the foundation of psychiatry on the island, but the overall system remains small, centralized, and largely evidence-based. So the progress in clinical expertise did not automatically translate into respect for human rights. There's a painful turning point that comes with the case of Longfa Tang. So as a religious organization in southern Taiwan, in Kaohsiung. So in the context of a limited psychiatric resource and strong stigma, and an underdeveloped institutional system, so many families send their relatives with mental illness to Longfa Tang for so-called residential healing. That's not really care. But in 1980, health authorities and the media exposed that Longfa Tang had confined more than 1,000 people. So under deplorable conditions, patients were trained or abused, or some died in custody. So the revision shocked the community, the country, and received intense media coverage. So they forced Taiwan to confront the gap between the medical knowledge and the basic human right into mental health care. So from a global perspective, this mirrors similar history elsewhere, the moral scandal that catalyzed legal reform and the shift toward accountability and right-based care. So in response, Taiwan began reconstructing its psychiatry service. So from 1985, the government introduced accreditation for psychiatric medical institutions. So since 1999, the Joint Commission of Taiwan has been responsible for evaluating not only psychiatric hospitals, but also psychiatric rehabilitation facilities and the psychiatric nursing homes. And in 1986, the Department of Health established several regional psychiatric hospital networks, laying the foundation for a system of regional division of labor and referral. And the legal reform followed in 1990. So Taiwan implemented its first Mental Health Act, so providing a legal framework for compulsory hospitalization and community care and the patient right protection. And in 2022, a major draft amendment was proposed to further strengthen rights, safeguards, and update practice standards. So our North Star has remained the same. It's the least restrictive care and robust procedural protection and the community of the nations whenever possible. So another important major turning point is the introduction of national health insurance in 1995. And the NHI has several important effects on mental health care in Taiwan. The first is accessibility and the service use. That greatly increased, but concentrated in medical institutions. So people with mental disorders have been covered under the same single-payer system as the general population. And the second is the care structure. So hospitals and the outpatient service have been strengthened, but the community and the psychosocial services have not been developed in parallel. And the care structure have become more hospital and outpatient centered, but community and psycho service have not expanded at the same pace. And the payment system favors short consultation and pharmacotherapy, and leaving limited room for psychotherapy and intensive psychosocial interventions. And the long-term hospitalization has become financially affordable, so which protects families from catastrophic costs, but can also prolong institutionalization if community options are insufficient. And finally, the NHI claims database has become a crucial infrastructure for psychiatry research and the policy monitoring. I think it's very important. Since we have the big data, we can do many things. So the modernization is not the same as normative. It's the discipline of aligning structures, incentives, and outcomes with what the evidence says patients need. So let me highlight the domains where Taiwan has modernized with results. Okay. So this begins with mental health promotion, not only focused on psychiatric patients and the suicide prevention. So for example, now Taiwan has an online platform for mental health knowledge that will provide validated scientific information and a digital learning resource for the public. And we have a 24-hour public suicide prevention hotline, which is toll-free and offering counseling, crisis support, and referral. And we have set up issue-based mental health promotion programs that targeting various groups, including people with ADHD or LGBTQIA+ communities, or people with internet addiction, indigenous people, or pregnant women. So open co-developed with local government and NGOs. And we have developed tailored counseling service, so currently provided by over 200 institutions, supported by trained and equipment to ensure the quality and the safety. And the second moderation pillar is our network of community mental health centers. It's designed as a hub of spoke platforms for everyday care in the community. They provide case management, community support, and resource referral, and the mental health services. So for a population of about 23 million, we currently have 64 community mental health centers in Taiwan. So our goal is to reach 71 in the end of this year, and then it's 100 in 2028. So the guiding philosophy is simple. So care should follow people, but not the other way. So now we can see the workforce for the mental health specialties in Taiwan. We can see that for psychiatrists or mental health nurse or psychologists or social workers or occupational therapists, they are all above the level in the high-income countries. But the distribution is not so even. So in urban areas are better served than rural and remote regions. So we rely on tailored mental health technique, outreach teams, and incentive programs to address this gap. And we can use NHI data, the data from the National Health Insurance, to evaluate some specific interventions. So one example is the use of long-acting injectable antipsychotic for schizophrenic patients. And our nationwide cohort studies have compared health resource use and the cost between the LAI user and the non-user, and find if we use the LAI, the patient will reduce the possibility of hospitalization and less emergency visit, so they can be well. So similar work has been done for patients with bipolar disorder following the introduction of LAIs. So for people living with a severe mental illness like bipolar disorder, long-acting injectable antipsychotic could reduce the relapse, reduce the hospitalization, and the overall care utilization. So it would be good for patients, for their family, and also to reduce the burden of the caring system. So Taiwan has evaluated real-world impact as new LAIs enter the market So the principle is clear. If the continuity prevents crisis, then financing and service delivery should favor continuity. And medication adherence, case management, and the smooth transitions between inpatient and the community care are very important. So this real-world data from NHI can move from access to any treatment toward access to the right treatment with better outcomes. That's what we can do from the database. And another thing is that we can use the NHI database to help us to link the clinical information with some biomarkers. They allow us to build a more personalized and precise treatment. So they could help us toward a way of a precision psychiatry. And in the coming years, we are going to put much more energy into the social factors that shape mental health. We will work through the communities using social prescribing and other community-based approach to bring social support closer to where people actually live and struggle. And another part is at the same time, we will keep building on Taiwan's strengths in AI, not just for technology sake, but to support mental well-being and to ease the burden of family, the frontline professionals, and the whole caring system. So looking forward, we frame our strategies as 4 key shifts. So first is from access to adherence and outcomes. So we are moving beyond the canteen visit and the prescriptions. We want to focus on continuity of care, functional recovery, and the quality of life, especially for people with severe mental disorders. And second is from programs to hub. So instead of fragmented and project-based funding, we aim to build stable hubs, such as community mental health centers that could host multiple programs over time and coordinate across sector care. And rather than isolated digital pilot projects, we want to build the digital plumbing, the infrastructure that allows our data, our apps, or decision supported by tools that flow safely and reliably into everyday clinical workflow. And finally, we want Taiwan to be not just a policy taker, but also a policy contributor. This means participations in global learning networks, sharing our data and experience, and the continuous learning from others. And this is another example of a digital clinic we try to develop in Taiwan. So in this model, we have combined active data from mental health questionnaires and also collect passive data from like smartphones to collect sleep activities. So in a smartphone app, people can access self-help activities and have online digital brief interventions. So on the provider side, we are testing the role of digital navigators. The team members who help patients to set up this app and troubleshooting for them and translate digital data into meaningful conversations during outpatient visits. So the goal is not to replace human care, but to augment it, making each clinical encounter more informed and personalized. But there are still challenges. Because modernization does not remove the challenge, it transforms them. And here are the challenges we face. The first is despite the progress, the stigma remains a major barrier. So our response is normalization. So public campaigns with real stories, school-based social emotional learning, and the primary care integrations, so that mental health consultation feel like ordinary as a checking blood pressure. And geographically still fragment cares, so we are expanding tailor-made mental health caring and deploying outreach teams and using incentive structures to stop remote areas. So smaller counties are paired with larger hospital systems for supervision and clear escalation pathways. And burnout is real, so especially after the COVID-19. So we are working to simplify the documentation, so invest in team-based care and build community in practice. And quality improvement must be benefit for both patients and for providers. And the last is the data governance. We can only modernize with data if the public trusts us. I think the trust is a very important word we have mentioned that today and also yesterday. So our stance is privacy first and transparency first. As we often remind ourselves, trust is earned slowly, but lost very fast. So I will conclude my talk. To close, let me step back to the beginner picture. So over the past century, Taiwan's mental health system has traveled a long road from the excellence-based care to human rights scandal and legal reform and the regional hospital network and the universal health coverage. And now toward the community hub digital integration and the outcome-focused care. So the questions we face today, how to reduce stigma, reach remote populations, sustain our workforce, and govern data ethically, are not unique to Taiwan. They are global challenges. So my hope is that by sharing our story, our success and our struggles, we can contribute to the global learning communities in which mental health systems evolve together faster and more wisely than any one country could do alone. And thank you much for your attention. I look forward to our discussion. Thank you.
Our next speaker is Dr. Cedric Carbonell. He joins our list of very, very talented speakers as a cross-disciplinary in work experience. So Dr. Carbonell started as an immunologist, began by training and conducting research, basic science research into HIV infection, with a particular focus on the role of dendritic cells and mucosal immunity. He then moved to translational research in the field of HIV infection as part of the European research projects, developing microbicidal drugs and in vitro tests. So the tests start to come in from the diagnostics. In the early 2026, he joined the French National Authority for Health, HAS, as a project manager. His work has focused primarily on assessing and developing diagnostic test methodologies in medical biology, genetics, and imaging. He assessed the appropriateness of the use of most common imaging examinations, such as X-rays of the skull, chest, abdomen, pelvis, and even echocardiography. In 2011, he joined the French Ministry of Health as an innovation project manager. In that role, he was responsible for defining the ministry's innovation strategy. And in 2016, he returned to HAS to oversee the Diagnostic Therapeutic Procedure Assessment Department, initially as deputy head and subsequently as head of the department. Since 2022, he has been the deputy director of the Assessment and Innovation Access Directorate as a member of the HAS Executive Committee currently. Welcome.
Good afternoon, everybody. Are you okay? Still on a little bit of energy for me? Okay, so, yep. Better. Thank you. First, I will thank the organizers to really give me the opportunity to talk to you today. It is a real honor for me to be there. First time in Taiwan for me, a wonderful experience. And then today I want to talk to you about the way we're going to use innovative diagnostic and therapeutic procedures to increase health and well-being in a particular topic. Wrong way. Okay. As you know, of course, there is a deterioration of health and well-being in certain situations, mostly illness, sometimes accidents, and the objective of healthcare, mostly through diagnosis or treatment, is to improve or restore good health and well-being. Thus, the objective of healthcare in that situation clearly gonna be aiming at the reduction of illness or accident-induced mortality, morbidity, and increase the quality of life, which has been previously altered by the illness or accident situation. But what we're gonna talk today is a particular situation for which sometimes an additional deterioration of health and well-being going to be also induced by the healthcare itself, mostly by treatment, for example, for their invasiveness, for operating complication, side effect of health products, medicine, medical devices, which are going to clearly limit the global benefit of the healthcare itself. Thus, since some years now, there is the development of innovative therapeutic and diagnostic procedures, which are going to also acting on this additional deterioration in order to restore the full benefit, mostly full efficacy, of the healthcare and health technology. Thus, nowadays, we're trying to have some health technology working on directly on the disease itself, but also trying to improve the way they're going to limit some side effect or limit also the bad effect of healthcare technologies. Let's talk about therapeutic procedure first. Classically, if I took, for example, surgical techniques, we clearly know already that there is a problem with invasiveness. And we have clearly innovative therapeutic procedures which can be alternative through already used or recommended classical therapy, which may clearly aim at lower the invasiveness. In that case, you're going to have, for example, the interventional techniques versus surgical techniques. You will have mini-invasive surgery versus classical open surgery. Through the same things, you're going to have also has objective to have a lower perioperative complication, or can be also a lower long-term complications. That also has aimed to higher the quality of life during or the perioperative period or thereafter the period, and also to clearly allow faster recovery and home return. There is today numerous innovative technology which are aiming this objective, and as an example here, in essential tremor, the classical recommended intervention today is deep brain stimulation. It's very effective technique, but there is some complication, and it's really invasive. This problem is taking account this invasiveness. It decreased drastically the acceptability of these techniques for patients. We're gonna be, for some of them, afraid of this intervention. And nowadays, we have alternative techniques, for example, the MRI-guided ultrasound thalatomy, which is non-invasive, which exhibit a similar efficacy, lower probability of safety, and thus which are clearly more accepted by patients and allows thus a more wide application of treatment. Other possibility still in addition to, to classical surgical intervention, if you quit the surgeon, you may have some perioperative nursing procedures which may also increase the altered quality of life of patient. If I take, for example, the preoperative soma site marking and therapeutic education before fecal or urinary stomies, this intervention by nurse will dramatically increase the understanding and acceptability of invasive treatment by patient. They're going to take some time, some bigger exchange with nurse and patient before the intervention. Going to show them where going to be the stoma, how going to be it's working. So the explanation with patient, giving them the time also to ask many questions that they have, clearly will increase the acceptability of these invasive treatments. It will also decrease anxiety, and sometimes gonna decrease also postoperative pain, but clearly will increase postoperative autonomy. And thus, overall, you will increase deeply the well-being of the patient following this kind of intervention that may be necessary in certain circumstances. Let's talk about diagnosis procedures. Here again, you will have some innovative diagnostic procedures that can be alternative to old recommended diagnosis follow-up techniques, which can be less invasive and or more acceptable for patient or, when it's children, for their parents. Two examples here. First of all, in the follow-up of the bladder cancer. As you may know, the recommended examination for the follow-up is iterative invasive cystoscopy. Not a really fun examination, especially for men. So you imagine if you need to do it once, 2, 3 times, etc., there is a problem, a clear problem of acceptability by patients and loss of follow-up, and then you're going to miss some recurrent resurgence of bladder cancer. So that's clearly a problem today. What can be proposed then is new techniques based on simple urinary samples, which are not non-invasive, and then gonna detect some molecular biomarkers, or which can have another approach by, for example, AI with pathology. And then, if, of course, they have the similar or a better diagnostic performance than the invasive cystoscopy, will clearly increase the acceptability of the test, will increase also the fact that more follow-up, complete follow-up will going to be performed, and then have an impact also on cancer residents, on health and well-being of the patient. Other example, the GLUT1 deficiency syndrome, which is here a rare disease, metabolic rare disease, and up to recently, the global, the overall recommended diagnostics test request a lumbar puncture in very young children. So you may imagine that for parents, they were not clearly agreed in numerous circumstances. And then this diagnosis was not clearly performed. But very recently also, a simple test was also developed, which is based only on just a blood sample, classical, and then allows to clearly the substitution of the test with the lumbar puncture, and then allows for patients and for parents to be with a lower anxiety to clearly state the fact that they will agree to make the test And then the quality of the diagnosis was increased. The number of tests was also increased. And then these patients can be treated, because in that pathology there is a treatment which is a simple regimen, specific regimen. Yep. Other possibility, the large use of companion diagnostics, and particularly through the use of the next generation sequencing, the NGS. As you know, in that situation, it allows the identification of genetic actionable alteration, which thus can be targeted by specific therapy, particularly in cancer, also in rare disease. Major objective of such diagnostic test is to give the access, wider access to personalized therapy with higher efficacy. You will identify some specific population of patients in which the treatment gonna have some efficacy or a better efficacy. But there is another additional role of this NGS in that situation of companion diagnostic test. Is the use of the pharmacogenetic approach. Because in that situation, instead of focusing on population for which the treatment has higher efficacy, we're gonna focus on population for which the treatment will have decreased side effect or non-side effect at all and reduced toxicity. It's particularly important in oncology, in psychiatry, as it just have been said before, in cardiology, and so on. Thus, according to specific patient genotype, you're going to be able to clearly identify the good treatment for the first try, instead of have an approach, an empiric approach, trying one drug, doesn't work, through another drugs, doesn't work, etc., etc. Using this pharmacogenetic approach, it would be able to directly target the good drug to the good patient, or targeting also the best dose adaptation for these people, or contraindication to certain drug for these people. For example, if you are on the, for example, cancer, where you want to give some 5-FU or capecitabine for patients, in certain situations, for certain people, it can kill them or generate severe side effects. But if you just perform a simple test such as erythrolemia, you will avoid this side effect. So it's clearly a way to to increase the well-being of the patient, because it's gonna allow clearly a better dose adaptation. It works also for example, treatment for radiotherapy also. So it's going to be really interesting to provide large access to these innovative and therapeutic diagnostic procedures, for example, through the reimbursement, in order to contribute efficiently to better health and well-being of patients. But there is one condition to that. If only it can be interesting if claim benefits have been previously and rigorously been proven. And one, or the best way to demonstrate that, is through the health technology assessment process, which will clearly assess the whole benefit of this treatment or diagnostic through the assessment on many outcomes. Of course, you will have the clinical outcomes, efficacy, safety, diagnostic performances, clinical utility, the quality of life, patients using specific generic quality of life scales, the patient-reported outcomes, of course, also some aspect from the organizational impact, and particularly on acceptability and accessibility for patient or for healthcare professionals. And one of the major things in that situation is clear and systematic patient involvement through the HTA process. in order clearly to have their input, their direct comment, to clearly appreciate the benefit for the patient of this technology. Thank you for your attention.
Thank you. Thank you once again to all the speakers this afternoon. 非常谢谢我们今天下午的4位讲师哦。So we have heard from Dr. Collignon about AI benefits and risks, how to guide users. We also heard from Professor Stephen Weber talk about the future of medicine, leadership in the digital era. And then we heard from Dr. Po-Si Chen from on global perspectives on the evolution and also modernization of mental health care in Taiwan. And lastly, we just heard from Dr. Cedric Carbonell about toward better health and well-being through innovative diagnostic and therapeutic procedures. And with that, we will very shortly proceed with the panel discussion, where we will invite all 4 speakers and also our moderator to come up for interaction as well as dialogue, and also to take some questions from the floor. 那么我们接下来呢，到2点50分，我们有一段时间来进行综合讨论，可以让大家针对今天下午听到的内容来向我们的讲师请益还有交流。So I now like to invite our moderator as well as the 4 speakers to come up on stage. 我们再次掌声欢迎我们的讲师，还有我们的主持人王教授。
Well, I want to thank everybody for your attention, and we have about 30 minutes for a panel discussion, and we are happy to take any questions right now to see if you have any feedback or comments, please. We'll get a microphone for you.
Thank you very much. Dr. Ram Sagi from the Israeli Ministry of Health. First of all, thank you for a very interesting session. And I have a specific question for Dr. Po-Si Chen. First of all, it's very good that you put the mental health in the spotlight. I think it's very important. In the past, in Israel, it wasn't like this. And I have a question regarding what you said, next chapter, shift 1, from access to adherence and outcomes. Is there a thought of integrating or unifying the mental health center with the general medical centers inside? I mean to integrate body and soul together, the same treatment in the same place, one-stop shop for the mental health patients in the hospitals, not in the mental health centers, but in the general medical centers together. I mean integration. I hope it's, I clear myself.
I don't know whether my understanding is correct. So you want to ask how to integrate general hospital and the mental hospital, or?
No, I mean if there was a thought to integrate the mental.
Sorry.
I meant if there was a thought of the next chapter
Yeah.
to integrate the mental health center inside the general medical center.
It's not inside the general medical center. It's we try to build many community mental health centers in the society, in the community, and this will serve as a hub to link with the hospital. The hospital will have a general hospital and also have a psychiatry specialty hospital. But when a patient leave the hospital, they will go back to the community, go back to their home. So the next step, we will establish more community-based programs for them, and then can have a service in the community. But only when they have a real necessity or real need, they will go back to the hospital for the inpatient care. Okay, I think, and so that will be a better adherence to the treatment program. So we will have some people to visit them in the community and to follow up the adherence. And the National Insurance Program has put a special budget, that's just like I mentioned, for the LAI for this population of patients. So the copayment is very low compared with other countries. And the hospitals don't need to consider the budget for the LAI use because there's a special budget. Okay, so after using that, more patients will leave hospital because their adherence is good. They will not go back to hospital, and the lab quality is better, and their family could have a work because they don't have take time to care in the patient. And the hospital have reduced the hospitalization. So the number of beds or number of psychiatric nurse or doctors, the working force could be reduced. Yeah, I think it's better for everyone. Thank you.
We'll take another question. Go ahead. Yeah. There are 2 questions right now, but go ahead.
Okay, thank you, Chair. Grace Lin Huang, the Senior Director of CDHTA Taiwan. First, very appreciate our speaker, informative presentations. I have a question for Corinne or Cedric. About, in your opinion, compared to traditional medical device, what additional dimensions should be included when conducting HTA assessment? Thank you.
The most important dimension that is pregnant in HTA for digital medical devices is the impact of the organization. And that's really something that has been put in France into the law to specifically recognize the potential of organizational impact of those technologies. So that's something we are working on because manufacturers have some difficulties to build evidence regarding that organizational impact. So we are leading some work to guide them to improve the demonstration of such a benefits. I think that is something else that we will have to explore. It is the implementation in healthcare. That is something that is not in our regulatory criteria, but we are thinking about dealing with that because we think that it is a lever for appropriation of such technologies.
Yeah, in addition to what Corinne said, one other problem that we have, which have been also clearly stated by Professor Weber, is very oftenly we do not know what is the question, what is the problem for which the digital medical devices was developed. So very oftenly we need to get back with the developer saying, okay, you've proposed this product, but have you really think before what is the problem of the current situation and what is the solution, and is your technique is a solution? So very oftenly we do not have the description on the initial organization and what's going to be the next organization using the digital medical devices.
Yeah, I want to add a little bit to this discussion here. So I'm based in Silicon Valley, so we have over 1,000 startups in AI, just in health alone, just lots of companies and digital health. And every year, about 300, 400 companies want to do a trial at Stanford, right? Everybody wants to do a trial at Stanford. So you could imagine we have to look at the workflow impact, we have to look at the potential budget impact, and it could be, disruptive, right? And then knowing that 99% of the startups are going to tank, they're not going to make it. So basically, it's actually a very high risk for the institution. It's also a very high risk for the startups because they have to demonstrate very quickly that their usability and integration into the health system. So it is a very exciting time, but it's also a very challenging time. So I just wanted to add a little bit to the discussion. I see a hand there. Do you want to ask your question and where you're from?
So, Dr. Nikita Haidukov, Head of Vinnytsia City Rehabilitation Center, Ukraine. Thank you very much for a comprehensive vision you provided, and I have a few questions, two questions actually for Professor Weber. So first of all, what's your thoughts about adopting AI in doctor education, in medical education? Not only in decision making, and the second one, what are the key indicators of reliable AI product in medicine, in your opinion? Thank you.
I think the second question about reliable indicators are, it's certainly challenging both on the part of the technology itself and how we're assessing the technology, but even as we're revisiting to a great extent what it means to appropriately train individuals as physicians as well. Even the folks who make a living in medical education full-time will acknowledge that we're really training physicians right now to practice about 10 years ago. Now, ironically, at least in the US, the folks who are going into medical training, they have an expectation of medicine and life that's far advanced where we are in the US in terms of the application of these tools, but yet the education is still predicated very much on brick and mortar clinics and traditional interactions. And so I think the challenge in assessing the second part of the question of understanding how effective it is that we have to first decide how do we measure the products, but then how do we measure what the goal is to train the students too. To the opportunity around it, I think it's an extraordinary opportunity for certain, and one of the tensions that we see is that there's an opportunity with the digital tools to broaden medical education, to make it more accessible in some ways and in some settings, depending on the availability of the technology, bandwidth, and whatnot. And yet, in many places in the world, there's still constraints on how many people will train, what the role and responsibility is going to be. So I think there's an enormous tension about, are we using the technology to broaden the nature of medical education, or perhaps to invite a wider audience of clinicians, non-physicians, into practice, or are we going, and/or will we apply it to make those clinicians better? I'll go back to where I left off in my remarks, which is that understanding what that metamorphosis looks like, how we're changing medicine, and working back, again, what's the problem we're trying to solve? Because what a clinician, I'm an infectious disease physician, as you heard, what an infectious disease physician may need to do 5 and 10 years from now may be very different. And I think we need to start with understanding what that ought to look like and then work back from there. We could go on about this a lot, but just some initial reactions, and I really appreciate the question.
I'll just add 2 cents to Professor Weber's response. So, I practice clinically. I have a teaching clinic of Stanford students and residents weekly. And what I do is that after they go see the patient, right, I'm like looking up stuff based on the initial chief complaint. I'm looking up it up to date. I'm looking up in ChatGPT, our version of the ChatGPT, because I know they will be looking up inside the, inside the examination room before they come out. So I cannot be, I have to arm myself with like all the tools I can. So they're looking inside, I'm looking outside. And then we have to do a differential diagnosis, right? So we have to go through, make sure we're not missing anything. But what the actual education is that they don't have the experience of seeing patients for 30 years. So they will come up with like some differential diagnosis that's like a little off. And then we have to go through sort of the diagnostic process. So you still need to train people how to think clinically about the diagnostic process. So one thing I fear is that people get lazy and they stop doing differential diagnosis and stop picking up subtle signs and history from the patient, stop asking questions and just rely on the AI algorithm. Then they will actually miss something big, because AI doesn't tell you the input. Like, you have to ask the patient what's happening, take a great history, make sure everything, before you could feed it into the AI. So that is still a lot of sort of doctoring happening there. And then you have to figure out exactly what problem you ought to solve. Is that social or is that medical? Half of the problem is social. Okay, so still, I mean, there's a lot to do in medicine, and we're just beginning to learn how to work with the tool that is that powerful. And yeah, Very famous Miss Chang.
Oh, no, not at all.
For the national health
Not at
insurance.
all.
Yeah.
No. Thank you. My question is for Dr. Chen, both as a clinician and as a policymaker, as you're the head of mental health department in the Ministry of Health and Welfare. The clinical question is, we all saw yesterday that suicide is among the top causes of death in Taiwan. And it's not only in Taiwan, but also in Korea, Japan, Singapore. I don't know about Singapore. In East Asian cultures, it seems. So what do you think are the causes of that? Is it a brain issue, or is it a social determinant issue, or is it a combination of both? What kind of correlation is there between these two? And as a policymaker, can you talk about what the policies, government policies are towards mental health, and what kinds of resources or additional resources would you need in order to put mental health in Taiwan in a good condition that you would like to see it in?
I think it's a very tough question. Okay, so I think the countries in East Asia are all facing the problem of suicide. The suicide rate in Korea, in Japan, in Taiwan, and Singapore is relatively high compared with other countries. But in Australia, I think they are better now. Okay, Australia, also. Okay, so I think the mental health is a behavior problem. So the behavior problem comes from the interaction of our brain and our environment. So the biological brain, the physically problem is one problem, and another is a contextual problem. So the culture, the development environment, like the child in Taiwan or in Japan, in Korea, so how they grow up, and like the low birth rate. So only one children in the family, that's quite different from before. And a very competition environment in the society, or the income, or is young people easy to get their housing, or get promoted, or how to keep their life quality. There's all the outside, there's social environment stress that integrate together to get the final outcome. But if we could have a much better, or have a better protective network, we still have a chance to help or to hold the patient to get the to be suicidal, to commit suicide. So there's a chance. Okay. So Taiwan have I think it's not only Taiwan, and Taiwan and the countries in East Asia, we all develop many different programs for suicide prevention. But I think it's very complicated, like how to say that, like the stock market. Okay. So like one day President Trump say one word, something, that tomorrow the stock market will change. Just like that, so the social environment will change. There's so many different factors complicated for that. Okay, so I think the difficulty for suicide prevention. And for more resource, I think in the one major difference between Taiwan and like US or Europe is in Europe and US, more NGOs or more non-governmental resource, they put resource into for promoting mental health. But in Taiwan, I think the stigma is still the one major change. So if there's a stigma still there, the NGO or companies, they might not have so many resource to put into for the mental health as a resource for mental health. Okay, and so the education, or that people know that mental health is a very important part of health. So without mental health, is without real health is very important. And when we, even the education in the medical school, mainly focus on the physical health before, okay? So maybe from the educational part, in the medical staff training and in the general population, we can change the concept. We are open-minded to facing this problem. I think maybe this is a beginning. But thank you. I think it's a very complicated question. I like a thesis proposal defending. Thank you. Thank
you. Any other questions from the audience? Well, maybe I could ask a question of our colleagues from France. How are you paying for the new diagnostic innovations or the digital medical devices? Like, how is that in terms from the insurance side? How's the government thinking about that? I know you have the HTA process, you have to show efficacy and you have clinical utility, but there are so many coming out, you know, and also AI algorithms on top of it. So you could have an analyte, and then you could have algorithms on top of that, you know, to provide analytics in addition to for example, a proteomic analysis plus analytics. That could be, you know, added on top of the innovation. So how is France thinking about this sort of approaches?
I will give a non-answer. It depends. It depends on the benefits. There are several models, and my colleague is much more involved in that topics. But for the digital part, actually we are at the beginning of the assessment we will have to do for new procedures. Embedded AI technologies. So we will see in the next future. Cedric, I think we do not have assessed any AI system through procedures until now, but it's coming. So we will see if the result allows a huge margin of negotiation with a French national payer. I think Cedric can complete my answer.
Yeah, to deal with the innovation, whatever the health technology it is, we have several conditional coverage system, mostly coverage with evidence generation, one for each kind of technology. One is dedicated for medicine, one is for mostly medical devices and more therapeutic procedures, as one is dedicated to procedures involving diagnostic test for medical biology or pathology. Process is very short. You may have a request from industrials or healthcare professional association. They send a request for which they have to demonstrate that the technology may be an innovation according to 4 specific criteria, which have been fixed by law, and then has its conditional coverage. It's conditioned to the performance of a clinical trial or health economy study. They have to provide the protocol of the study. We check the protocol in order to be sure that the data that can be collected through this study will be sufficient for formal HTA thereafter in order to status on the reimbursement or not of the technology by NHI. These systems are for medicines in France since 1996. Because they were introduced for the first anti-HIV drugs. And for other technologies, more recent, mostly 2015. So it works really good for medicines, for diagnostic tests, biological ones also, a little bit less for medical devices and therapeutic procedures. At this time, we have no digital or AI product within this conditional coverage system. There are two under assessment, so maybe in a few days or months, we're going to start to have the two first. And for classical HTA assessment for reimbursement, probably they're going to come next year. We are waiting for the answer of the manufacturer because they have their own study ongoing. So normally it should be finalized next year. So I think they're going to make a request probably end of next year or in 2 years. So it's really coming. It's knocking at the door of reimbursement, clearly.
Yeah. Well, they say somebody passed the criteria in France and want to go to the rest of European Union. What do they have to do? Do they have to qualify for each country, or is there some way to qualify in France and get a speedy qualification outside of France in the European Union?
I'm not sure to understand the meaning of your question. There is in France the same regulation as in Europe for a product to be sold on the French market. It is for a device and a digital medical device, the CE marking. That's a prerequisite. Then our assessment, for example, is to inform on the benefits and the added value of a device in the context of healthcare. So it's something that can be argued by the first data used for CE marking, but sometimes we need more data, especially comparative data, to demonstrate the added value. Is it the... did I catch well your question, or?
Well, you know, so the nightmare for any innovator is to have to qualify for, you know, different countries, different continents. Yeah. It's a nightmare. Yeah. And then with AI, you could have bias in the data.
Yeah.
Depends on who you collect the data from. Like US is so diverse. I mean, if you only collect data from a certain social demographic group, then you're not gonna get a very good algorithm. And then when you test it in another group, it might not work. And so, you know, different countries are handling it differently. And even with the same group, you use the algorithm for a long time, it might change because it overfeeds itself. And so, you know, there's all these complications to the qualification process.
For this issue, we built several years ago a grid that target the characteristic of the AI system. Some information very important from the learning data. The data used, the characteristic of the data used to test, and also some requirements regarding what is done to evaluate robustness, etc., etc. Some very important key points that come in addition to the, I would say, the clinical data to show the benefit and the added value. There are key issues regarding the robustness and the validation of a tool in a local context, for example, and even the entry data in hospitals can be very important to have to make the AI system in a local context very performant. So they have algorithms to personalize sometimes the tool. It's important when we talk about AI and assessment, and that is a part of the key question that a professional and hospital has to target, is to have those specific information on the technical characteristic of a solution, of a device. very important, and it's come in addition to the evaluation, classic evaluation of the benefit and the added value and clinical effect and etc. etc.
And just in addition, there is also a huge similarity between the way we're going to assess AI technology and diagnostic test, because they share the same bias, the same way to develop. So it's easy for us to very identify what's going to be the problem and what kind of study must be performed. So that's something which is reassuring in the way we're going to assess them.
It seems like you have a great framework, like starting with like recommending different things and then testing them, allow innovation to go on, not over-regulate. And this is all great. Do I see a question from the audience?
I'd like to ask a follow-up question on your question.
My question.
Yeah, a follow-up question on Professor Wang's question on HTA in France. Is HTA in France function the same way as the UK NICE, the National Institute for Clinical and Care Excellence, and the German IQWiC, which is also a quality assessment, HTA assessment? See, and also, does the French HTA agency, do you make insurance coverage decisions? And what happens once you make that coverage decision? Does your health insurance have to pay by law, like UK NICE? Any recommendation to cover by NICE, the NHS must cover?
Clearly no. We assessed methodologically similarly to NICE, except for procedures for which there is no health economic assessment. That's the case for a health product by HS. But in France, for procedures, health economic assessment is performed by NHI. That's a particularity. But HES is only consultory. So we provide advice to NHI, and the NHI is free to follow us or not. There's no mandatory things. But in fact, they follow us in 99.9%, clearly.
A quick follow-up. Does your HTA have a threshold? Like the English NHS has a 30,000 pound threshold above which, even if it's clinically effective, because of the big budget impact, they do not cover. They don't have to cover.
Not for the moment. There is a huge discussion within the HAS about the relevance of thresholds or not, or single threshold or multiple threshold. At this time, there is, for the moment, no threshold in France.
We have time for one more question, because I think we have to finish on time, and then we have to take a photo. So, one more question. One more. I'm looking to the left, I'm looking in the middle, I'm looking to the right. Any more questions? If not, you could catch any of the speakers. Oh, Dr. Benjamin.
George Benjamin at the American Public Health Association. This is more of a comment than a question. You know, every newspaper story about AI, the fundamental headline says, will AI replace physicians? And the answer is obviously is no. Jason, you said the point. At least until Star Trek, we get the Star Trek hologram that can actually get the input in. Until you do a good physical exam and take a good history, the AI is still going to always be a tool. It might help us with the analysis, it might help us think it through, but I just got to remind people that any good medical student, every good instructor has taught their students that if you take a good history and you take a good physical exam, the diagnosis will become very apparent, and diagnostic tests are only confirmatory. and AI is also, I think, would argue that. Does anyone disagree with that?
Well, I think I would totally agree with that. But I tell you one use case of AI that has helped my life a lot, which is, when kids show up, I'm a pediatrician, when kids show up with like fragmented immunization history and I have to figure out how to give them catch-up shots, and I input it into AI and they give me a schedule and I checked it, it's exactly right. So they are much better in, these type of algorithmic analysis than humans are. But it may be also true in some cases of antibiotic, use at least for non-experts to identify at least the initial few antibiotics. But I'm sure, that has to be refined somehow.
Yeah, I mean, it's obviously a provocative question. I want to answer in the same way that you do, but I think continuing to ask it becomes the good question, because I'll riff off the scenario you gave, and I do the same when I'm mentoring folks in the clinic. When that person comes back, are they now receiving my knowledge counter to the AI, or are they also receiving my bias and my experience? And so I think we need to continue to look at the interface more and more. And we just talked about, and you used the example, that a diagnostic test is just a tool. So what constitutes anemia? Is it a hemoglobin, or is it the physical findings and the symptoms that go with it? It ends up being both, really, as different folks will exist at different levels with varying degrees of comfort. But I think the most important thing that we can do is keep making the observation, keep asking the question, because the moment we sit back and say it can never reproduce, or that we will always, we have to deconstruct what it is that we actually do better. And it's not going to be everything, but at the same time, the tools are not going to perform to the hype that we hear right now. So let's keep asking the question together and be disciplined as we do so. So thank you.
Let's give a round of applause to all our panelists.
Thank you. Thank you to the panel, and I'd also like to thank our moderator, Dr. Wang. Before we wrap up, I'd like to invite Dr. Wang to present certificates of appreciation to each of our speakers. So I'd like to invite everybody to come forward. 我们最后呢，请王教授来帮我们颁发感谢状给我们的每一位讲师。So first of all, I'd like to invite Dr. Wang to present a certificate to Dr. Collignon. Please look into the camera in the center. Thank you so much for sharing with us your insights and also experience. Thank you very much. And now I'd like to invite Professor Weber. Dr. Wang, please. Thank you. And now Dr. Chen, sharing with us his insights from a policymaker's perspective. Thank you. Thank you very much. Last but not least, Dr. Carbonet. So again, please look into the camera. Beautiful. So lastly, I'd like to invite all the panelists to come forward for a group photo. 好，最后我们邀请讲师还有我们的主持人一起来合影一张。So remember to smile. Thank you very much. 我们再次谢谢所有的讲师，还有我们的主持人王教授。各位与会的贵宾，我们接下来呢将进行20分钟的休息时间，请各位到1楼的点心区来享用茶点。我们在3点10分的时候，将会在1楼的101会议室来举办这次论坛的最后一场主场会议 Plenary 3 Smart Healthcare to Safeguard Public Health。那么请大家呢在3点10分的时候再回到1楼的101会议室。 So ladies and gentlemen, this concludes this session. Please take a 20-minute break. You can enjoy refreshments on the first floor and make your way to the plenary session 3 on smart healthcare to safeguard public health in room 101 on the first floor by 3:10. Thank you so much for joining us, and we wish you a great afternoon and rest of the day. Thank you.